This is a look at our agenda for today. We'll have about 2 talks and then breaks, so hopefully we can stay more or less on schedule. We have a wide-ranging agenda looking at melanoma detection and total body photography to the latest treatments in terms of advanced disease and a lot about side effect management and survivorship. You will notice a slight reordering of our end of the day. We usually end with the patient stories. One of our keynote speakers is from Australia, and it will be about 6 in the morning, is my understanding, when she's giving her talk. So to have her go any earlier seemed kind of inhumane. So she'll actually end up with the last presentation after a patient story. So just for awareness there. We seem to have lost it. I wonder if I did that somehow. That's okay. A couple other comments. So, not sure if that's projecting to the online audience. The event will be recorded. So you will get, oh, there we go. It's okay. Everyone who's registered for the event will get an email to the recording. So if you're, wanting to balance feverishly taking notes, these materials and presentations will be made available to you after the event. So you can certainly focus on that. Oh, sorry. To the online folks, this is a webinar, so you can post questions using the chat function, but there's no video or audio exchange with the online audience. There is a way to communicate and ask questions. If you accidentally close out of the webinar, you can rejoin the webinar by clicking on the link sent to you in the details. There we go. We're back. We're back. We will try to have a Q&A after each talk. I often find that to be the most interesting part of the presentations is the engagement with the audience. We've tried to allow time for that. So please think up questions to pepper our speakers with. Lastly, I'd like to thank the MRF, who continues to be a great partner in hosting this event, the Melanoma Research Foundation. They'll give a presentation after lunch, but please visit their table outside and learn about all the educational and advocacy activities they're up to. They've been a long-standing partner in this event and a major reason we continue to have it. There's also a variety of materials on the table outside related to our melanoma research activities at Fred Hutch. There's a research pamphlet for those that are interested, and other ways you can get involved or learn more about what active research is happening here at our cancer center. We're not quite ready for a break, so I'm going to go back. With that, we will kick off our program. It is my distinct pleasure to welcome Dr. Tanya Hathaway to give our first presentation. She is a clinical associate professor of dermatology at UW-Medicine. She cares for a large number of patients with skin cancers at both the Roosevelt Clinic and at Fred Hutch Cancer Center. She's a Northwest native who also went to medical school here at University of Washington. And she has, since joining our program, really been instrumental at deploying some of our new melanoma screening interventions and really getting this total body photography system that she'll talk about today off the ground and running. So she's really a pivotal person in this effort. I can think of nobody better equipped to give this talk about this new technology than her. Dr. Hathaway, thank you for presenting today.
Thank you so much. Such a pleasure to be here and see so many familiar faces as well. I just want to start the day by saying it's a little ironic that we have the boat show going on next door at the same time and place as the melanoma conference. I'm here today to discuss with you, excuse me, an introduction to our Vectra system. What I'd like to do is start the day with some statistics and information around screening for melanoma and why the screening is important in certain high-risk select groups. And then we'll talk about how The Vectra system can be utilized to do this high-risk screening. I have no disclosures. This is Chloe. All right, so just a quick dive into some of the epidemiology around this. Estimated new cases for 2024, 100,000 folks. Overall, we have an excellent 5-year survival, 94.1% between the years of 2014 to 2020. So that's where we have survivorship being so important, is because this is a wonderful number. If we look at the overall incidence of melanoma over the last several decades, we'll see that for many years, the incidence has been going up. But as we look closer at more recent numbers, what we find is we actually see a flattening of that curve. And in certain populations, especially in men, there's actually been a deflection in the overall incidence curve of melanoma. So in general, it does seem to be that we're getting the message out about the prevention side of things if we're starting to see these curves start to level out over time. Interestingly, we also see it in the pediatric population too. This is a paper that was just published in the Journal of the American Academy of Dermatology last month, looking at the young folks, the teenagers, and the very young. And we also see in the ages 5 and up a deflection in that curve in the incidence of melanoma as well. So this is all very promising news. If we look at mortality, we even have more good news that we can see with the advent of some of these therapies that we're going to continue to hear about today. We've seen a sharp dive in the mortality, beginning with these targeted treatments for folks in all age groups as well. So that means that we need to do surveillance in folks who've had the diagnosis of melanoma if we know that we are able to make such a positive impact in people's survivorship. When we think about surveillance, we have to think about the different types of melanoma that exist. The vast majority of melanoma that we see out there, and probably the vast majority of melanomas that exist in this room, were the superficial spreading type of melanoma. These are the kind that tend to have an outward growth phase that we can actually catch versus a deep dive growth phase out of the gates. When we think about the melanomas that grow rapidly and tend to go deep very quickly, oftentimes we're thinking about what we consider the nodular melanomas. These are very challenging to pick up in any sort of a screening program because they can double in size even as quickly within 1 week. So to diagnose these, we need to see those in real time. When we're thinking about melanomas that we can do surveillance for on 3-month schedules, 6-month schedules, 12-month schedules, we're mostly focusing on melanomas that give us a clue over time that they exist. And that's where we have the superficial spreading type, lentigo maligna, which tends to be a very slow growing melanoma on sun-exposed areas, particularly in the elderly, and then acral melanomas that tend to occur on the hands and feet. So if we think about these different types of melanomas, and we think about the stage that we catch them in, the vast majority we're still catching at the localized stage because they're that superficial type of melanoma. If we look at survival by stage, we also see that those are the folks that we're going to be doing that long-term following for because they have excellent survival. So who's at risk for all of this? We do know that there's certain risk factors that we can predict ahead of time that makes folks at risk for particularly the superficial spreading type of melanoma. And you can see over on my right-hand side of the slide here that if you have the combination of lots of atypical moles that have been diagnosed, a family history of melanoma, and a large mole burden, that your risk of melanoma is the greatest over the course of your lifetime, 35-fold. We also know that there are predictable genetic mutations that make folks at risk when they've had a positive family history of melanoma. And as work and genetic research continues to go on, we continue to identify more of these mutations that exist out there. In the general population, the average risk of melanoma over the course of anybody's lifetime is approximately 1 in 50. When we think about those risk factors that we all just saw, that number drops down to 1 in 7 to approximately 1 in 8. And those are the folks that we want to focus on in terms of doing high-risk surveillance. How do we do that monitoring? Well, it turns out that all of these areas are typically exposed when we think about using systems like the Vectra, which we'll get into. For women, their highest risk area is on the lower leg. For men, it tends to be on the back or trunk. So these are all accessible areas that we can start to use photography up for to manage the number of lesions and changes in lesions over time. For this crowd in particular, we also know that having had a history of melanoma is an additional risk factor for future melanomas that may occur. As survival rates continue to improve, we know that people are living with the initial diagnosis of melanoma much longer. And our job in the dermatology world is to find any other lesions that may sneak through. The incidence may range as much as 20% in folks who've had a prior history of melanoma, of their future risk of an additional melanoma. Fortunately, they do tend to be that superficial spreading type when they're diagnosed, not the nodular type, which means we can capture those changes over time by doing high-risk surveillance. So how can we do this high-risk monitoring? What we do know is that the combination of doing whole body photography along with serial digital dermoscopy tends to be a two-step combination that helps us to diagnose melanoma both earlier and to start to reduce the number of unnecessary biopsies in high-risk individuals. This just shows that this was a consensus paper from 2021 where the majority of dermatologists that are queried do believe that this combination approach of doing whole body photography along with serial digital dermoscopy is the best way to manage high-risk individuals. So what is that? Total body photography is a tool that can be used to take multiple high-resolution images of the entire surface of the body. When you do this and you follow those photos over time, you can see a definite trend that it becomes easier to find not only the new lesions, but the lesions that might be changing. When we think about finding lesions that are changing, we can find melanomas at a much earlier stage. What is serial digital dermoscopy? All of the folks in here who have seen a dermatologist has seen a dermatoscope, I guarantee it. That's that handheld device that we all use when we want to look closely at the architecture, the color, and other salient features to diagnose melanoma. When we have the capability of doing high resolution images of those moles with the dermatoscope, we can start to look for even smaller changes that help us predict that transition point to melanoma. So this is considered a two-step surveillance where we have the combination of both whole body photography and serial digital dermoscopy, which has emerged as the most sensitive way to detect malignant transformation. So now we're going to switch gears here a little bit and talk about what the Vectra system is. This is a fairly new system that is designed by Canfield that in an all-in-one system combines whole body photography with the ability to do that serial digital dermoscopy. What it is it's 92 different cameras taking polarized images of the body surface with the exception of scalps, genitals, palms, soles, that creates a 3D avatar through the reconstruction of these two-dimensional images through the software graphics, which I'll show you here in a second. So this is what the machine looks like. It looks like a very large airport scanner. When people get in it, everybody assumes that it's also a cancer scanner, but it is just a very expensive camera. As you can see, it takes all of these representative images, and the difference between this type of a system and traditional photography that exists is other forms of photography that's been utilized has always been two-dimensional photography. When you have the capability of doing the three-dimensional approach, you get much more accurate assessment and representation of what the actual color, contour, and specific features of the different lesions on the body look like. So this is what gets created out of all those two-dimensional images. This is what we call the patient's avatar. This is a fun little video showing in what type of detail we can now mark all of these lesions on the body. Another feature of the program that we can utilize is being able to look and capture all of these moles in one single image. This spiral diagram that you can see is this person's, all the moles that are being photographed laid out in picture form in front of you. And what we can start to see emerge is towards the center, we can start to define variables where we can see the ugly duckling or the thing that looks different from this patient's signature mole type. The ugly duckling sign is one of those signs that we use to identify which of these lesions are going to be the highest risk lesions in this individual. This system also has the ability to do dermoscopy as well as that serial digital dermoscopy. This is called lesion tagging when folks come in and do the Vectra system. We identify lesions that we may think have some features that make them stand out as looking a little different from the rest that we want to follow over time. And we're able to capture these very high resolution images of these individual lesions as well. When we do the Vectra system, we're also able to do full body comparison of all the moles at different points in time. This allows us over time to not only see changes in individual nevi, but to also pick up new lesions that are emerging in folks as well. And this is what that looks like with an individual lesion that's showing changes over time. So does any of this really work? There's been multiple studies that have been done over the last several years that have validated this system in terms of being able in this study to pick up new lesions. As you can see on the lower pictures there, that's a brand new mole adjacent to a previous excision site that was picked up using the Vectra system. And then validation studies, also showing that it works also for doing the serial digital dermoscopy in terms of helping to pick up subtle important changes that direct you towards knowing where the biology is changing and lesions that are worthwhile to biopsy and check for folks. Additionally, studies showing that once people do this system, there's a high level of trust and a high level of patients being comfortable with the technology to aid in the diagnosis and help to identify lesions that are changing. Thank you so much. I'll take any questions.
How widespread is this technology here in the Northwest? How many machines are available? Just one. And it's here at the Hutch?
Mhm. The closest would be California. San Diego, I believe, has a machine. And then some in the Midwest, and then more over on the East Coast. Mhm. Interesting, Australia and New Zealand just bought, I think, 18 of these machines to start doing high-risk screening in that high-risk population throughout those countries. So they're definitely believers in the system.
Does Medicare cover this?
Well, I'm not going to get into the billing side of all of this stuff.
So the answer
Please
is,
don't ask me the billing questions.
answer is no. Okay, thank you.
I believe at this time Medicare is covering the costs. There's also folks who do patient intake who help through private payer insurance to run and see if there's coverage. Some private pay insurances are covering, some are not. But the complicated aspect of all the different Medicare plans, I don't want to get into today, hopefully.
So if patients are interested in pursuing this or looking into it, what is the best way forward?
So it's done by a referral system. There's certain criteria that folks would meet in order to be eligible for doing this high level of monitoring. And then having your current dermatologist or oncologist put in a referral for the system to Fred Hutch.
How does having tattoos impact it?
So when we look at, for instance, the spiral diagram that I showed you, it's very confusing for the system. And even when you're looking at a patient in real time, you really have to individually look closely with that dermatoscope through a tattoo. So the larger the surface area of the tattoo, it almost becomes like a clothing area that the system isn't going to be able to pick up on subtle changes.
I was just wondering if there's like a radiation component to the photography or if it's just photography.
It's just photography. Yep.
Could the system be like customized for areas like scalp or feet or genitals if those are the areas of high risk, or is that just not possible with the
Not at this time. The only adaptation for hair-bearing areas is for hair loss to do counts of hairs. But no, even in certain individuals that have a higher density of body hair, when we're using some of the embedded software in the machine to have the machine help us look for subtle differences, even body hair can change the morphology. So we are limited by the fact that this is just photography.
Is AI used at all in this with the photography?
Sir?
Is AI used to help view the moles from the
So that's a
photography?
big area of research at this time. I'm sorry, I didn't see who, I don't know where to look. Actually, thank you. Thank you so much. So that's a big area of research and a large, huge body of work for this system at this time. Any sort of AI component is not ready for prime time. So this is all at sort of its infancy in terms of being an self-automated system. Right now, it's a tool that we can use as dermatologists, but it still requires a human brain with it.
One question from online. I think the crux of it is for patients who already have an advanced melanoma, maybe like something that's already in the stage 3 to 4 range, how would you think about who would be useful to deploy this technology for?
So for anybody who's had invasive melanoma, one of the things that we're always checking for when people come in and we're feeling around the scar and looking around the scar is signs of either local recurrence or signs of recurrence far away from the initial site. If it's present on the surface of the skin and it has a color that the machine can see, then this machine would be useful in potentially picking up in transit mets or distal metastases in that way. It's not going to feel or see any nodules that are under the surface of the skin. So a proper skin exam still is required for folks like that.
Great. I think two more questions will go here and then to the very back next.
Can the machine pick up pink melanomas? Most of the photographs you showed were in the brown tones.
An excellent question. So some of the newer studies looking for, so if we think about which melanomas are pink, we know folks who carry those BAP mutations can make pink melanomas. And then we also know that some of the desmoplastic and the amelanotic melanomas are more in the pink ranges. And those are the hardest and most subtle melanomas for anybody to diagnose because you're really relying on vascular changes for that. So if we ask the question of, if we know that there's a vascular tumor such as a basal cell carcinoma, which one of the hallmark features is large blood vessels that are in it, how well can it pick up basal or squamous cell carcinoma? Turns out less than dermatologists can in a skin exam. So whatever you're asking a machine to do, the more directed the function, usually the better the machine is going to perform. So at this time, the highest performance of this machine is in the pigmented lesion range.
So
Excellent question.
to the back,
Oh,
middle, and then.
First of all, thank you very much for your very interesting report.
Thank you so much.
My question is, please tell me, is there still any difference between 1.0 deep in melanoma and less than 1 millimeter deep? I mean, thickness of melanoma, is there any difference in the protocol of treatment? Do you get me?
Let me repeat the question. If somebody's had a melanoma at a depth of 1 millimeter Breslow depth or greater, does it change the way we do monitoring for future melanomas?
I mean, in protocol of treatment, with lymph nodules or without lymph nodules?
So I think that's a more complicated question regarding treatment of melanoma beyond the talk about surveillance for melanoma.
I'm sorry.
Yeah, that's okay. That's okay. I'm going to save that for the treatment talks.
We have one more and then we'll move on. If there are other questions for Dr. Hathaway we don't have time for, if you send them to us afterwards, we're happy to distribute that to her for comment.
Since the images are all digital, and I noticed in the pictures that you're limited to the human visual spectrum, have you looking at ultraviolet or infrared, going beyond the human visual spectrum for taking these photographs?
What's been shown to be the most helpful way that we can look at structures of pigment is through polarized light, visible spectrum of light. I'm not aware of any research studies looking at infrared dermoscopy or UV dermoscopy types of changes. Mostly it's been polarized visible spectrum light.
Is this machine, would it be able to look at those spectrums?
Not with the current configuration of the cameras. We have normal flash photography and polarized flash photography capabilities.
Great. I love the Q&A. It's my favorite part. Thank you so much.
Thank you so
Dr.
much.
Hathaway. All right. Can you guys hear me okay? I switched to this portable microphone. Is that sounding okay in the back? All right. So I like to move around a little bit, so maybe that'll be a good choice for me. So I'm not going to introduce, well, I'm going to introduce myself in the context of the talk, but we're going to talk about some of the work that we've done in the last few years at the Hutch about the survivorship experience of people after systemic melanoma therapy, after immunotherapy exposure. There are many examples of people living this in the audience or who have had family members exposed to these medications, who've had toxicities. And so we'll be talking about that today. I hope you find it interesting. I don't have any disclosures. Well, we did partner with an app technology company for one of the studies I'll tell you about, Wave Health. And I don't think any of the other disclosures are relevant to what we'll talk about here. So I got interested in this area because I think of where I was in my training when immunotherapy happened. So I graduated medical school in 2012, which didn't used to seem that long ago, but now seems further and further ago, which was right about the time that IPI, or Yervoy, as some might be familiar with it, was first approved for use for metastatic melanoma. Really the first modern immunotherapy came online right as I was graduating medical school. And then as I was in my fellowship, combination immunotherapies came to light. So I was seeing this in real time as I was in melanoma clinic. We began to use immunotherapy for high-risk patients after surgery. And then I've been here at Fred Hutch since 2019, 6 years now. So I trace my interest in this to a specific experience that I still remember from my fellowship. We had a patient, a middle-aged woman who had been diagnosed with metastatic melanoma involving the liver, very serious situation. She received 1 dose of the ipilimumab-nivolumab combination, also known as Opdivo-Yervoy, and developed a very severe neurologic problem related to the treatment that resulted in her being in the hospital for a few months recovering and really precluded her from getting more treatment. She finally recovered to the point that she could leave the hospital, and we said, well, wonder how the melanoma is doing. So we did a scan and it was smaller. And she was still dealing with so much of the side effects from the first dose that we decided to just watch her. And for the next several years, and this is now, I think, maybe 18 or 24 months ago, was my most recent report from my colleagues down at that institution. Every time she had a scan, the melanoma got smaller. 1 dose. And she's, at the same time, lived with years of the consequences of that single dose of therapy. So it really is a highlight to the power of this whole class of medicine, the incredible power for good that a single dose can result in a 7-year remission from a metastatic melanoma, but also cause ongoing side effects that can last for years or long term. So that really was the kind of spark for my interest in thinking about the experience of people receiving these drugs. I've certainly continued to make observations similarly in my clinic since then. So a simple agenda for today. We'll talk about why this is important, the number of people who are living after exposure to immunotherapy drugs is rapidly growing. And then we'll talk about some of the work that we've done at Fred Hutch in the last few years to try to understand how patients are living and what opportunities might be to improve quality of life for long-term survivors. Before we get started, I intended to do this earlier. Show of hands, who is the first symposium? Is anyone here who has not been? Wow, okay, it's about half. I mean, it's about half. I was just interested. I was aware we had a lot of first-time registrants, so very exciting. So I don't want the takeaway from this talk to be that immunotherapy is horrible. And oh my gosh, I don't want that to be the takeaway. It's actually been amazing. And in many cases, truly miraculous. This was the course of things before our modern melanoma therapy, back in an era where what we had was high-dose IL-2. I know some people in this audience have received this treatment. We don't do this much anymore. It was really toxic. It was only given to really healthy young people who had very few comorbidities. And even in that very elite group of people with advanced melanoma, the average survival was less than 1 year. And there were very few patients who lived long-term. So again, this is a curve showing the percentage of patients that are alive on the left from 100 down in time. And there were a few long-term survivors, some of which we have amongst us today in person or online. But it was very rare. It was incredibly toxic, and that was what we had. So we have thankfully improved markedly on this. But I highlight this at the beginning just to say, immunotherapy is amazing. And then let's talk about all the problems with it. So we often talk, probably every year we do a little bit of a brief introduction because everyone's coming to this from a different understanding of what these drugs do. At a high level, the immunotherapy drugs work by releasing some natural brakes on our immune system and having a net stimulatory effect. The goal is to try to coax the immune system into doing something new that it's not doing, help it recognize the cancer and engage. And the foundational class of medicines are called the PD-1 or PD-L1 medications. These are drugs like Opdivo, Keytruda, also known as nivolumab or pembrolizumab, very foundational to our melanoma treatment. And they work in a very simple way. When your immune cells encounter cells in the body, be it cancer or normal cell, they engage in some handshakes, some contact that helps the immune cell, the T cell, the lower part of this figure, decide if the immune cell should attack the cell of interest or not. And when this blue handshake on the left side of the screen happens, the PD-1 on the immune cell and the PD-L1 on the tumor, that is a suppressive interaction that is likely to turn the immune cell down and increases the chance that the immune cell leaves the target alone. And in the case of cancer, we don't want the immune cell to leave the target alone. We want the immune cell to kill the cancer. So all Keytruda and Opdivo do is they block that handshake. They stick to one end of this synapse or handshake, and they don't allow it to happen. And remarkably, for a third or 40% of melanoma patients who have metastatic disease, blocking that one handshake is all we need to trigger the immune system to attack the melanoma. This can be very profound and result in long-term survival. So I still think it's kind of amazing that this works so well for people where it does. The issue is this is a very fundamental part of our immune system and our body's ability to maintain tolerance to normal parts of our body. So this PD-1, PD-L1 interaction helps our immune system leave normal parts of our body alone. So when we block it, the immune system can get confused and it can cause inflammation of essentially any body tissue. Hard to predict what it might be for some individual person. So we're not really doing any sort of specific cancer-targeted treatment. It's a really broad manipulation to our immune system that for some patients with melanoma works really well. I'll just highlight this because many in the room will have experienced a drug called ipilimumab or Yervoy. It actually works a little differently. It is a medication that blocks a suppressive interaction that our immune system has with each other. So the immune system is incredibly complicated. We're learning about it all the time. I would say more than half of what I learned in medical school about the immune system has been proven to be wrong in the last 15 years. So we are making progress, but our immune cells interact with each other and try to coach them up to get them to attack or leave alone different targets. And Yervoy or ipilimumab works on an immune interaction to try to boost the T cells, and that can then downstream also cause cancer cell death. So just a slight difference from the other, but the concept is the same. A broadly stimulatory effect on the immune system by removing some of these natural brakes, and then hopefully immune system attacks cancer, cancer dies. So this is where we are now. We now have 10 years of follow-up from the foundational study of nivolumab with ipilimumab, 2 immunotherapies together for patients with metastatic melanoma. And at 10 years after diagnosis, nearly half of patients who are treated with that regimen are alive. And what's notable is that most people who are alive at 3 and 5 years are alive at 10. So it seems like for most patients, this immune system control of the melanoma is long lasting, and we don't see it waning for many of these patients now with 10 years of follow-up. So it really is remarkable. It's not perfect. So we're not going to talk, later parts of this talk, Dr. Veatch is going to talk about ways to try to help enhance the immune system effect against the cancer for those where this doesn't work. But there are definitely patients who need better treatment, and some loved ones of some in the audience, these treatments, as amazing as they are, weren't enough to help the immune system engage the melanoma. So I don't want to discount that. But the focus of the rest of this talk is going to be on these people, the people that are alive 5, 10 years after a diagnosis of metastatic melanoma. What do they need? How are they feeling? And how can we help them live better? So if we think about all the patients that are now being offered or treated with these medicines, used to just be stage 4. Then we started to use it for stage 3. And now we even use it for high-risk stage 2 patients, or at least it is an option for them. It's been shown to reduce recurrence risk for stage 2 melanoma. These are patients with only a melanoma skin tumor, no involvement of lymph nodes at the time of surgery, but a deep, high-risk melanoma of the skin. They're eligible to receive these drugs. So if we go back to Dr. Hathaway's slide, most melanomas are diagnosed localized. Now a chunk of those localized patients are actually candidates to be exposed to these medicines, and sometimes they can have side effects. So another way, just over time, how we have increased the pool of patients that are potentially going to be receiving these medications from initially just stage 4 to stage 3, now including some stage 2B and C patients. I found this statistic and just wanted to highlight it. Over 1 million Americans are living after melanoma diagnosis. Dr. Hathaway nicely summarized that most people who are diagnosed with melanoma are alive 5 years later. So we have a large pool of survivors, and you're not alone. So this is actually 1.5 million people. It's a large number. So what do we know about how people are living after they're exposed to treatment? I would say we don't know enough. So if we go back to that study that showed that nivolumab and ipilimumab transformed long-term outcomes for melanoma, this is the data from the quality of life aspect of that study. So most cancer clinical trials of new medicines administer questionnaires to patients who are going through treatment to try to understand what their quality of life is like. And there's a baseline questionnaire, and then periodically during the study, they complete additional questionnaires, and they're scored, and the quality of life is assessed in number, and then it's compared to baseline. And this is the data from that very transformative study of nivolumab and ipilimumab. And I go to a lot of meetings where this data is discussed, and almost always it looks like this. It looks like, no, 0 is stable quality of life. These are the 3 different treatments and 3 different colors that people got in the study. It's kind of around 0. Seems good. Seems like it's not really impacting quality of life. And what's so interesting about this study is that in the red arm, which was the most effective arm, about half of patients stopped in the first 12 weeks because of side effects. So we have a real weird phenomenon happening here where the treatment is having to be discontinued in half of people because of toxicity, and we don't see it in the quality of life data. So that's been an interesting observation. We've done some research into that. That's not going to be directly addressed today. But I would say the going belief from many oncologists is they go to meetings, we see data like this, and it's like, oh, immunotherapy, not too bad for quality of life. And I think what's happening here is we're basically compressing hundreds of experiences together and losing a lot of resolution. So what's amazing is for some people with ipilimumab and nivolumab, the quality of life is not impacted. They feel fine. I see patients come into my clinic. They've gone through 4 doses, 1 year, 2 years. They really have had very minimal side effects. That's amazing. And then other people have devastating or really severe side effects. And when you kind of smush everybody together and look at it as one giant 300 patient block, those individual experiences are not represented. So how did we try to address this? We'll talk about some of our own work. To preface this, I would say we actually know a fair amount about acute or early onset immune toxicities. So this is a picture that is kind of frightening if you look at it too much. Basically shows all the different parts of the body that can be inflamed by the immune system when we give immunotherapy drugs. In a way, I think this means if this term precision oncology is often thrown around, let's be precise, let's only target the cancer. I would argue that our current form of immunotherapy is about as imprecise as it gets. We broadly turn up the immune system. We hope that it results in a cancer impact, and then we monitor for all these different things that can happen as a side effect of it. So these are things that happen early on in treatment usually, and these are pretty well described. I'll note in this diagram the prevalence of the suffix itis, I-T-I-S, which is the medical word for inflammation. We're pretty good at capturing stuff when we know what to call it. So we like to label things in medicine, and if someone has abnormal liver tests, we would say that's liver inflammation or hepatitis. There's a whole another group of syndromes that we don't have a good itis name for. And I would say fatigue is probably the thing I see most in my clinic among survivors that is really hard, besides calling it fatigue, to put it on this map. It's not listed here. Why are people fatigued? There's a lot of different reasons. Maybe it's from adrenal gland issues, thyroiditis. Sometimes we can't identify any itis and people just don't feel well. Well, that's really, I think, where we're beginning to learn a lot, but where we still have a lot to learn are in these more difficult to classify situations. So there has been some pre-existing research about late side effects or toxicities. We have to define things somehow, and so these have been defined as side effects that emerge after 12 months since immunotherapy initiation. And here's a pie chart on the right showing what types of things emerge late. And a lot of them are kind of similar to some of the things that emerge early. And then there's, I should actually say on the right is what's called chronic immune-related adverse events. These are things that arise after stopping. So people have looked into this phenomenon. And I've discussed this with some people in the audience that the side effects started after. In this study, there were about 40% of patients whose side effects emerged after they were treated, or they persisted for at least 3+ months after treatment stopped. So these didn't get better with time. And they tend to be a little different. They aren't things like the bowel and the lung. These are things like the hormone glands, the joints, the salivary glands, things of that nature. So this is what's been described. So I think there's a growing appreciation that these things exist. This is an interesting schematic showing the frequency of which different acute or early side effects can become chronic. And it's very clear that the hormonal side effects are the ones that are most likely to become long-term. Those glands, if they're affected by the immune system, tend not to improve. So when we sought out to do our research here, there were some limitations of the work that I've just described. This has all been reported through doctor-derived adverse events, which is, again, we tend to get into itis land. We call it itis, hepatitis, pneumonitis, thyroiditis. Not in the patient's voice, not in terms that mean things to them. So these are physician-reported. And we know from prior research that what patients experience and what doctors report is not highly correlated, or at least there's a lot that's lost in that translation from what the patients are experiencing to what goes in the doctor's clinic note. And if you've looked through your portal and you read a summary of a visit you've had with your doctor, you might realize that a subset of what you talked about actually makes its way into that written document. So most of what's been done uses the doctor's note as the gold standard. Not perfect.
Yes, it's fully charged.
Oftentimes, it's limited to early follow-up. So we now have 10-year survivors. Just showed the curve, 43%. We don't know anything about 10-year quality of life. I'm just going to tell you that now. That data doesn't exist. We need to gather it. But most of what's been done is in people on treatment or just after. Most importantly, we don't understand what symptoms or issues people are having and what impact that then has on their overall life function. Lastly, most of the studies have just taken, that's all right, it's exciting. I could imagine doing a study where we had all the melanoma survivors in this room. I gave you all a questionnaire right now. I got a lot of data at one point in time, right? How many of these symptoms are present every day? How many of them are present 3 months from now? How many of these are truly things you're experiencing on an ongoing basis? The existing efforts to look at this at a single point in time cannot tell us that. We cannot learn about the persistence of the symptoms by that approach. So most of the work I'm going to share today is the result of what we call our ImmunoWave study. This was a collaboration with Dr. Jones. She is a psychologist at Fred Hutch who builds quality of life instruments. That is her research. She builds the tools that are then used to assess quality of life in cancer patients. And Anissa Chan, who was originally a member of our research team and then went on to get an MPH, and she also picked this project up and helped carry it forward. So what do we do? Many of you, some people may have actually participated in this study in the audience. And if you did, I really appreciate it. We used a smartphone app and we administered questionnaires via the app. And we tried to be a little bit less prescriptive about what questionnaires we asked. We tried to view things more from the patient symptom perspective. So we'll talk about that. And we also looked at quality of life. And this study was initially done in people who had been on long-term immunotherapy or people who had been on treatment and stopped. We partnered with an app technology company who was great. They basically made a modification to their app to allow it to do what we needed it to do for research. We took patients, most of whom had melanoma. There were also a few kidney cancer patients. I also have a kidney cancer portion of my practice who are treated with the same medicines, actually, very similar treatment. And we really didn't want to measure melanoma symptoms. That was not the goal of the study. So we took patients and they needed to be doing well from a cancer perspective, meaning that they're on an ongoing effective treatment plan for over 6 months, no signs of growing or resistant cancer. So we're really trying to hone in on what's from the treatment. And they could have already completed treatment and been in a surveillance setting. And then they just needed to have access to a device that could do the app. And we gave weekly assessments for 12 weeks. So trying to address that limitation that, some people in the audience today are experiencing fatigue because they got up early to drive here from, far away. Well, does that mean they're having fatigue regularly, or is that just a today thing? So we tried to address that by doing repeated assessments and doing things in the terms that mean something to patients. So instead of saying arthritis, asking about joint pain. Instead of saying dermatitis, asking about rash or itching. So we used questionnaires that are used to give to patients directly that talk about symptoms, not about itises. And then we also looked at quality of life information broadly in the way that's usually done on studies, like that graph I showed you. So we got to use a really cool app that I couldn't have designed myself. If I had designed the app, it would have been really clunky and not very stylistic. And everyone's used to using Uber and stuff. And so we had a nice tool. So this was a screenshot of the interface. This is what the questions are. So for assessing for muscle pain, we ask about aching muscles, which is something that is not, we're not asking about myalgias, which is the medical term. So trying to use words that mean things to patients, asking about frequency, severity, and most importantly, is this interfering with your life? Like, is this a significant thing that you're experiencing? And there's a whole bank of these patient symptom questions that are available to any researcher to use. So this is probably the most important data slide, and I should say this is clearly not confidential because I'm talking about it and this talk's being recorded, so you can disregard the bottom. This work's being submitted for publication now. What we learned is this group of people whose cancer is doing well on immunotherapy, they have symptoms commonly, and sometimes they're severe. So 43 participants completed 317 questionnaires for us during the study. And if we just look at 317 questionnaires overall, the symptoms in the boxes in red were present on over half the questionnaires. So over half of the completed questionnaires, there was at least mild fatigue, joint pain, depression, anxiety, muscle pain, itchiness, numbness. So that's pretty common. Now, again, maybe it's just mild. Some are more often, some are more significant than that. But if you think about having mild itchiness for years, that maybe doesn't sound so mild anymore. If it's mild itchiness for a day, maybe that's okay. So I think that the persistence is interesting. And sometimes these were severe. So this is looking at the 43 individual participants. How many of the 43 respondents reported severe symptoms of this symptom during the study? And 20% or higher of the participants reported severe itchiness, severe muscle pain, severe anxiety, severe depression, severe joint pain, severe fatigue during the 12-week study. So sometimes these things are not just mild, these are more significant and impactful. We also looked to try to see about that persistence question. Are we just catching people on a bad day? Are people more likely to report symptoms when they're, just in the mindset of filling out this questionnaire? And most of the time, the symptom persisted in most of the assessments that were done. So for people that had a symptom, when they reported it, it was present on over half of their weekly assessments. So these things persisted. Another way to look at it is like this. If we just lined everyone on the study up at week 1 and looked at how often symptoms occurred during the 12 weeks, these are fatigue, joint pain, depression, itchiness, very stable. These things do not go wildly up and down. So that's another kind of suggestion that these things are ongoing, persistent. Some of the more novel things that we were able to do, this has not been previously done, was look at the co-occurrence of symptoms, right? So I'm going to tell you, I don't understand the fatigue. If I see it all the time and people come in and they say that they're more fatigued than they used to be, and their thyroid test is normal, their adrenal gland test is normal, and they're not anemic, I don't understand the mechanism. I'm sure there is one, but I don't personally understand it. So maybe we can begin to have clues if we look at things that flow together. So what we saw in this small pilot study was that fatigue is commonly seen alongside other symptoms, which is not entirely surprising. I highlighted in green here the things where over half the time one symptom was present, the other symptom was present, kind of the intersection of this table. So things like depression and anxiety being co-occurring kind of makes sense. Those are both in the broad mental health space. But fatigue was really the key hub. So when fatigue was present, there was a high chance of having other associated symptoms running down the left side. So this is something we're looking to continue our exploration of as we do larger follow-up study. We also began to get the first glimpse at which symptoms may be the most impactful in terms of overall life function and quality of life. So this is a really busy slide. On the left, we have the symptoms. So these are the patient-reported symptoms through those questions like we talked about, the joint pain question. On the right are different ways of analyzing the quality of life data. And this is looking at associations between the symptoms and the quality of life data. It's a little confusing because anxiety, depression, and fatigue are quality of life things and symptoms. So that's the left half of the table. I actually find on the right half of the table more interesting. So two of the main domains of quality of life are physical function and social function. So we got to see which symptoms, when they were present, were correlated with lower overall quality of life in this, again, group of patients whose cancer was behaving. These are the people that kind of treatment is working, so to speak. And we learned that for physical function, depression, not surprisingly, was correlated with worse physical function. And also not surprisingly, things like joint pain and shortness of breath. When those were present, physical function was lower. Those make sense. You'd have mobile joints. We'll hear from Dr. Singh about joints soon. And you need to be able to breathe to move. So those made sense. What was really interesting was on the far right. So things that, when present, associated with decreased social function or enjoyment in social activities. Fatigue, I could have predicted. You kind of have to have energy to engage with others. But itching, which is one of my something that I frequently think about because it is one of the most common things people report to me after they complete treatment. And it often bothers patients. It almost never sends people to the hospital. So it's never represented in some of the standard things that are reported in clinical trials. But when patients had significant itching, they reported decreased satisfaction and social functioning as well. So again, this is very kind of pilot level, but really begins to allow us to say, boy, we're going to do a study where we take people with chronic itching or chronic fatigue, like which symptoms should we focus on? Where can we get the most impact in terms of quality of life improvement? And this kind of data starts to point us in that direction. So we learned a lot from this study. One was that patients were really willing to do this. So we didn't really know. A lot of these patients were off treatment. They're going about their life. They're back working. Were they going to want to spend time doing this? And overwhelmingly, the answer was yes. So that was gratifying that we could actually collect the data. Using the app worked well, but it had its own limitations. So we talk about the future direction. Really want to get more understanding of the depth and richness of patients' lives in survivorship. And the app is hard because very few people can complete, 100 questions on an app. It's just not comfortable to do. But it did allow us to do frequent, repeated questions. Symptoms are common and they persisted. And if you're in the room or your family member has been exposed to these treatments and are having ongoing symptoms, I would suggest this data says you're not alone. Other people are experiencing the same thing. And we also established that these symptoms may not be running entirely independently, that some of these seem more likely to co-occur. So I often think about this when I'm in my clinic. So before I meet somebody, they have a life. And everyone's life's different, but it often involves some combination of work, family, hobbies, interests, pursuits, travel. It's different for everybody, but there's some life. And then they're diagnosed. They meet me as a medical oncologist, and that's disruptive. And I would say usually, at least in many domains, people experience some downward change in their life quality during treatment. And that's probably normal. I think cancer is kind of like a trauma. It really is. It's a traumatic event. So to expect no change in how your life looks or how you feel about it is probably unrealistic. But it has a tremendous amount of impacts beyond symptoms, impacts on finances, relationships, things that are really complicated. But there's a downtrend. And then in this group, these are people that are mainly going to post-treatment. So they're off the infusions, maybe coming in once or twice a year for scans. And what does their life look like then? Does it get back to the prior height, or are there still long-term impacts and changes that are different? And I would say my observation from my clinic is that for some people, it gets pretty close to where it was. And for others, it's not complete. The return is limited by ongoing symptoms, fatigue, perhaps an inability to work in the same capacity they were before, or ongoing concerns about cancer recurrence that are really disruptive and impacting. And these are all things that we've talked about at this symposium in the past, and we'll be talking about some of them today. But this state where I think many patients appear to be alive, but less well than they were before their treatment in a long-term state. And how do we try to bring this upward part up higher? And I think symptoms are important, but they're not all of it. That was another learning from the first study, is we really weren't able to assess, who's feeling well enough to go back to work, who's playing golf again if golf was something they liked to do before. What are these other kind of softer things that go beyond symptoms that really impact how we spend our time and enjoy our life? So that has fed into our second project, which is called the Icicle Project. Again, a collaboration with Dr. Jones. We brought in Dr. Lee, who is a world expert on chronic immune toxicities from bone marrow transplant. So a different type of immunotherapy, but she has a tremendous amount of expertise looking at how to measure chronic side effects in a different type of immunotherapy. So we've leveraged her expertise. Others in the room may be participating in this study. We just finished adding on new patients, but the goal is different. So we are going to measure symptoms. We are going to measure quality of life. We're not going to do the questionnaires as often, but we want to understand additional elements of the survivorship experience. We want to understand financial toxicity, how people are spending their leisure time in terms of physical activity, a broader sense of wellness to include things like sexual satisfaction, work performance, how people are enjoying their hobbies and activities, and also thinking about fear of cancer recurrence. So in a few years, if I invite myself back, since I'm now the chair of this, I'll tell you about the results of this study, or maybe we'll disseminate it some other way. But I think that the concept is moving beyond just the symptom into the whole life composition and fabric, and trying to understand that better. So this work takes a ton of people and effort. I have mentors, collaborators. We got funding to do this, part of which through the Fred Hutch Survivor Program. So very indebted to them for helping us fund this work. My colleagues, many of whom are your doctors or your loved ones' doctors in the right column, and nurse practitioners helped us move this work forward. And our research team who helped really carry out the logistics of gathering the data. So with that, you may note that we're meeting in April this year, and that was a new thing. Usually this is in May. And when we decided to do it in April for just scheduling purposes, I was like, well, I hope everyone still comes. Clearly that's happened, so that's great. And actually, as it turns out, my wife and I are expecting our second child next month. So it would have been a little harder to do this next month. So it actually worked out great to be in April this year for us. We may eventually go back to May, but for this one-off, this worked perfectly for me. So with that, I would love to, I think we have some time for questions. So we'll open it up.
Dr. Hall,
Sorry.
I'm over here.
For the hands. Oh, there we go.
You know you'd hear from me. Thank you. Thank you. Thank you. My late husband was originally diagnosed in 2012, late stage. Wonderful doctors, metastasized in 2019, put on nivolumab for a year, but then he had a recurrence of his original melanoma, put on another year. So in that 2 years, he napped every day, but other than that, he was good. What I want to say is I kept a journal every day from the time of his first nivolumab treatment to a few days after his death. He died 2 years ago last month. I would encourage you to do that because a lot of times, you know, we see things daily and you kind of think, oh, it's okay. But I would encourage you to do that. He was great the 2 years he was on nivolumab. A month after he developed severe psoriasis, Dr. Musheri is his dermatologist. And then in December, autoimmune limbic encephalitis, rare, but it happened. The limbic area is your short-term memory and emotions. Short-term memory isn't just day-to-day. He lost several years. And then about 9 months after that was his second metastasis, and we knew he couldn't go back on nivolumab. In fact, his dermatologist, Dr. Lee, said it would be catastrophic, and his neuro-oncologist said he would probably lose all brain function. So he went into hospice. He died at home. If you want to talk to me, it's great. I've been a caregiver through the whole stage. Seattle Cancer Care, awesome. But what I want to say is it was rare, but I looked at that laundry list I was first given, and I would encourage you to do that. Don't be afraid. I'm not saying this for you to be afraid. Just be aware. These are wonderful drugs. It gave us 2 years we wouldn't have had. We would do that all over again, but they're toxic. So keep a journal and be an advocate. Be an advocate for your loved one. If you don't think something's right, say something. Thank you.
Dr. Hall, thank you for your presentation. With the data that you collected, was there any time frame post-treatment, and maybe you said this, but when symptoms started showing up for patients who had gone through some of these immunotherapy treatments?
Great question. Critically thinking about that first study, we weren't really designed to answer that because we took kind of a heterogeneous group. So with the second study that we're in the process of analyzing now, we took people who were in the first year after stopping. We were trying to disentangle people who were on long-term treatment from those who had actually stopped and were just on to monitoring. So I think we'll get more into that. I would say I've seen people who appear to develop new side effects for at least a year after the last dose. That's certainly been well described. I think beyond that, new things arising, it seems possible. We know the drugs can linger in the body for weeks and months. At some point, they do wash away. So, if something happened 5 or 10 years later that was brand new, maybe it's related. It's harder to understand, but we really need that data. So I think we'll be doing the long-term follow-up studies too. It's a great question.
Yeah, I have a question about the development of arthritis. I have existing arthritis, and before going on this therapy, I stopped all of my anti-inflammatory medications, and subsequent started back on NSAIDs for the most part. Prior to that, I'd take prednisone every now and then if my arthritis is bad. It's in the back, and so it's not functional. Question really is, how far can I go with anti-inflammatory medication?
Great question. You picked I don't know if this is your first symposium or if you've been here before. We have a whole joint arthritis section after the break. So I might defer some of that to our expert speaker, Dr. Singh. But the reason I invited her is because that is one of the other things we hear about in clinic all the time. And it's sometimes hard for us as oncologists to know, what's wear and tear. A lot of people with melanoma are in their 50s, 60s, and 70s. Like just in the general population, there's joint pain and arthritis issues anyway. How do we know when it's worse or exaggerated or is related to immunotherapy versus just the normal kind of stuff that people live with day to day? It's really hard. So I think I'm going to try to sidestep that question and give it to Dr. Singh next. A couple more, and then we'll have our break. Sure, I'll come down to you in a second in the front. We'll go back here.
You talked about this study was the IPI-NIVO study. Is there a similar study going on for Pembro or brentuximab?
So I would say the data for pembrolizumab, the other kind of commonly used immunotherapy, looks very similar to the data for nivolumab or Opdivo, that there are a significant fraction of long-term survivors and that people who are doing well 3, 4, and 5 years out appear to continue to generally do well. There are examples of people who have melanoma recurrence late where something changes and there's a recurrence later. Those are just rare. So I would say that the message is consistent, which is for people that have a good immunotherapy response at the 2-3 year time point, seems like there's a high chance of that becoming a long-term phenomenon.
I've got the microphone here. Just a comment and a question. First, one of the studies that you were talking about in terms of the severity of symptoms, I found it really interesting in that while I was going through the whole process, it became my normal. So I would have rated it a whole lot lower, but now I can look back on it and go, wow, yeah, you had a lot of fatigue. You really weren't eating very well. Your joints hurt. And so I just think that now looking back, I would have rated it higher. So just kind of a comment. And then my question was regarding spindle cell melanoma. Have you found that immunotherapy does much of anything with spindle cell, or is it so rare that you haven't had the opportunity?
Two excellent questions. I would say to your first point, that's a really important observation and a limitation even of the work I've done, which is, we really would love is a baseline, right? So like, how did things feel before? And obviously getting people administered a questionnaire 6 months before they're diagnosed with cancer is hard. It's hard to know who those people are. But even early on treatment, so that is a future goal, is to make this basically a living registry where patients who are start completing some of these symptom questionnaires, and they continue for years. That's what's been done with the bone marrow transplant patients, and has been incredibly powerful to learn from. So that comment about what's your reference, like, I feel this way now, but compared to what? And sometimes we don't actually know until we stop treatment, a year or two go by, and people are then able to identify, as you said, stuff that they were experiencing, and the time just kind of became the new normal. So I think that's really important. That is one theory that's been suggested to address why those quality of life curves look flat, even though people are having side effects on the studies, is that people just kind of adapt and they kind of adjust their expectation for quality of life in a way. The spindle cell, it is a rare subtype. I would say I don't view it when it comes into my clinic as more or less likely to benefit from immunotherapy. I'd have to, I don't think there's any compelling signal that says immunotherapy never works, that it always works, which is kind of in the gray zone like other types. So I think that would be my best answer for that. Let's do.
This is sort of a repeat of some of the question that was asked, is the comparison to general population, and then also by age. I noticed in some of the data, it only goes to age 65. And is that because we're all going to experience fatigue and joint pain after 65? So yeah, the general population particularly.
So great. And we'll just to prepare, we'll do your question and we'll answer the question from the gentleman here in the front, and then we'll have our break. Make sure we get 10 minutes. There were patients on my study that were, I think, in their 80s. People were down to use the app. So we did not make cutoffs about how old someone was. And I would say it continues to astound me that I don't think age is a great predictor for much in terms of the experience of treatment. I have a couple patients in their 90s who are flying through, doing great on immunotherapy, and I have young patients who struggle a lot. So I think it is an interesting variable, but not totally predictive in a way that's very interesting, because we certainly know for chemotherapy and things of that nature, it's a better predictor for who's going to have more severe toxicity. So yeah, I think that was my answer to that. We'll come down here. Do you have a question, sir?
Well, my question's already been answered about comparison, but I would say that you can have fatigue, depression, and anxiety just by reading the newspaper.
That's a great point. So I do.
Science and Rehab Medicine Department at the UOW in the 1960s. And we had a chronic pain program, and the patients would keep daily journals. I think the woman who made the comment about this is a very cogent point about trying to deal with this chronic disease.
I agree. And to your point about the reference, you're right. I think that the eventual big study that goes across multiple cancer centers, that's a much larger undertaking, will have to have some sort of control group to try to understand how much of these symptoms are enhanced in our post-cancer treatment population. You're right. If we went down to Pike Place Market and just asked people to rate their fatigue, it would not be 0% just among people without cancer. So that's very well taken. Great. So I am going to adjourn us for break. We'll do 10 minutes. So at 35 after, we'll resume with the after break part of the program. Thank you. Very excited to welcome our next speaker, who's one of my colleagues in our melanoma medical oncology branch. Be introducing Dr. Joshua Veatch. Dr. Veatch is a double doctor. So an MD was not enough for Dr. Veatch. He ended up doing an MD and a PhD at University of Washington. He's been around this campus, he says, for 20 to 25 years in various roles. He is a true scientist. So he has his own research laboratory where he is trying to develop the treatments of tomorrow. He's an assistant professor at UW in medical oncology and focuses on skin cancer. He's also an assistant professor at Fred Hutch in the Translational Science and Therapeutics Division. His laboratory studies how our immune cells, like our T cells, can recognize and attack cancer cells and how to help make this work better by engineering modifications to our immune cells and looking at things like vaccines. This topic that he's speaking on today, I just had so many people ask me about it in clinic. I said it needs to be on our symposium so that you can hear about it from an expert. So the idea of using personalized cancer vaccines in melanoma. So please welcome Dr. Veatch. Thanks, Josh.
So, okay, seems like the audio is working. And I'm really excited to be able to have a chance to talk to all of you guys. I was bad and I didn't make a disclosure slide. So I'm gonna say disclosures. And I think the most important disclosure for this is that I'm talking about research. I'm talking about treatments that are in clinical trials, but that haven't been proven and that they work and they haven't been approved by the FDA. And the companies that sponsor these trials do give money to the institution to run the trials, but I don't have any personal financial stake. One of the companies is Moderna, the other company is Amazon. And unfortunately, my main financial relationship with Amazon is giving them money. But I just wanted to start with that. And people are excited about the idea that we might be able to take vaccines that we've always thought of as used for infectious disease and preventing infections like viruses, to be able to use them in cancer and to use them when somebody already has cancer, to use it as part of their treatment. And in order to talk about vaccines, I want to sort of move back a little bit to talk about the immune system and how it works so that we can understand how vaccines work. And so your immune system has a very difficult problem to solve, which it has to be able to find cells that are infected with a virus. And the principles that the immune system uses to eliminate cells that are infected with a virus is similar to the principles that they use to get rid of a cancer cell. And so when you get a cold, the cold virus invades the cells that line your nose and your throat, and it hijacks them and it turns them into cold virus factories that pump out copies of the cold virus. Meanwhile, the cold virus is hiding inside of the cell. And your immune system has to be able to get rid of those cells that are infected with the virus in order for you to get better. And it has this very difficult problem. And one of the ways, it's a combination of two things that your body uses to be able to solve this problem of how to get rid of these virally infected cells. And one of them is that all of the time, every day, constantly, your cells are constantly chopping up everything that's inside of it and then bringing it up to the surface so that it can show things that are inside the cell to the immune system. And then your immune system has to be able to tell the difference between things that are you and things that are not you in these things that are brought to the cell surface. And the way it does that is with T cells. So T cells are immune cells that your body randomly makes millions and billions of different receptors on the surface of the T cells that function like a lock, where they're looking for the specific key that opens that lock. And so they're millions and billions of different possibilities because your immune system has to see a bunch of things that are foreign, but it doesn't know what it's looking for. So it has to make lots and lots and lots of different potential options. And if it finds that specific key that's on the surface of the cell that fits into the lock and turns the lock and opens it up, that's specific recognition. And so what your immune system does is it makes billions of these, and then it gets rid of all the ones that recognize self. It's the only ones that are left recognize something that's not you. And so if your T cells go off into your body and now recognize something, they know that that's not you, and they know they need to attack that. And so when your cell is infected with a virus, it brings out a piece of the virus to the cell surface, and then if a T cell that's specific to that specific what we call antigen, it recognizes that key turns and the T cell says, okay, this must be foreign, and it kills the cell. And this is how your body gets rid of virally infected cells, and also how you can get rid of cancer cells through a similar mechanism. And the idea behind vaccination is that this process of going from 1 in a billion to having enough T cells to be able to get to the right place to kill the virally infected cells takes a week. And during that week, you're sick, and that stinks. And so the idea behind vaccination for viruses is what if we can ahead of time make it so that there are a lot of T cells that are specific for the virus and they're ready to go. And this is the sort of protective immunity that keeps you from getting sick when you get exposed to the virus. And so we want lots of T cells, we want them rearing to go, and we want them ready to attack the antigen that we care about, that's the viral antigen. Every vaccine has two components. You have to have these antigens that we want to train the T cells to recognize and attack. But if you just give the antigen on their own, your immune system actually learns to ignore those. That's actually how an allergy shot works. If your immune system sees an antigen over and over again, in the context of everything being normal, your immune system learns to ignore it. So to build a vaccine, we have to have two pieces. We have to have the antigen we're training the immune system to attack. And we need a second signal that gets the innate immune cells angry so that it tells the immune system, hey, this antigen is foreign, and this is really important that we mount an immune response against it. This second signal we call, it's a danger signal to the immune system that we call an immune adjuvant. And this is the thing that when you get a flu shot or a COVID vaccine, this is the thing that makes your arm sore, and this is the thing that makes you have a fever the next day. It's not the actual pieces of the flu virus. And so it turns out that cancers, particularly melanoma that forms on sun-exposed areas of the skin, have a lot of genetic changes that have been induced by the sunlight. And some of those genetic changes can end up being presented on the surface of the cell, and they can be something the immune system has never seen before. This is what we call a neoantigen or a new antigen. And so your immune system can recognize these new antigens as being foreign. And so your immune system and your T cells can attack cancer cells just like they were a virally infected cell. And so the idea, what we often see spontaneously happening in patients with melanoma is that there are T cells that are trying to kill the cancer cells that are there already. And these are the T cells that we're trying to reactivate with these PD-1 inhibitors and CTLA-4 inhibitors. And now LAG-3 inhibitors as well. And so these are the same T cells we're trying to activate, but people have long had the idea, well, if the T cells are so important and these other treatments don't always work as well as we want them to, can we help them work better by increasing the number of T cells that are attacking the cancer with a vaccine? The same idea as we're trying to have there be a lot of T cells that are rearing to go against a virus. Why can't we do the same thing with T cells that are attacking a cancer? Give a vaccine to try and increase the number of those cells and increase their readiness. And so one of the problems that we've run into when we've been trying to do vaccines in patients with melanoma is that most of what the immune system recognizes as being foreign in melanoma cells is different between different patients. And so lots of people with melanoma that starts on sun-exposed areas of the skin will have hundreds or even thousands of different genetic changes. And those genetic changes are different from patient to patient, with a few exceptions. But most of what your immune system recognizes as foreign is patient-specific. And so if we want to build a vaccine that targets those genetic changes that the T cells are seeing, it's got to be a new vaccine for every patient. And we've got to figure out, what do we build the vaccine against? And so with the advent of sort of cheaper full genome sequencing, we can actually do that. We can get a sample of the tumor, we can get a sample of normal cells from your body, and we can sequence the genomes of both of them and ask, how are they different? And then we can use a computer algorithm to predict which ones of these genetic changes are likely to be recognized by the immune system as being foreign. So they have to be made into a protein. The protein has to be changed in a way that when it gets chopped up, it gets brought to the surface. And once it gets brought to the surface, it has to interact with a T cell in a way that activates immunity. And we in multiple companies, we being the scientific field as a whole, has developed computer algorithms to try and predict of these genetic changes, which one of them is likely to be seen by the immune system and important for attacking cancer. And this process takes time. And so you have to do the genome sequencing. You have to make a new vaccine for every patient. And once you get these vaccines, which are usually a mixture of different potential antigen targets, then you can finally get the vaccine. And this process takes time. It takes, depending on the sort of pathway that's being used, it takes 2 to 4 months. And one piece of trivia that I think is very interesting is that the need to make this process fast is part of why companies that were working on cancer vaccines ended up being the first companies that made COVID vaccines, because they had a pathway for making a vaccine quickly and getting a vaccine into a patient quickly. And so particularly companies like Moderna had a way to plug the COVID sequence in and have a vaccine quickly into phase 1 trials, which is part of the reason why they sort of won the race to having the first approved COVID vaccine. And so the idea here behind the vaccine is that we have a patient that already has a cancer, and we give them a vaccination to try and make it so that there are more T cells that are attacking the cancer. And that vaccination has a combination of this danger signal to get the immune system activated, as well as the cancer antigens to try and provoke those T cells. And I'm going to talk about one clinical trial that's been published that was run by Moderna. And this was an mRNA vaccine. And so it's similar to the vaccine that a lot of people have had for COVID. And they did this vaccine in the stage 3 setting, where people had lymph node involvement, everything was removed surgically, and there's the concern that there's microscopic metastatic disease in other places in the body. And these patients were all given the PD-1 inhibitor pembrolizumab or Keytruda. And the difference is some of the patients were also given a personalized vaccine, where they sequenced the patient's tumor, they predicted the antigens, and they made mRNA vaccines for each patient that were unique to that patient. And then they gave them the vaccine in combination with the PD-1 inhibitor once it was ready. And again, it took a couple of months. And what they found in this trial, which was a phase 2 trial that was randomized, was that the red here, this is progression-free survival, and the red here is the group that got the vaccine, and sort of the red curve is a little bit higher, showing that those patients did a little bit better. This was a relatively small trial. There's a much larger trial that is currently fully accrued. We had patients, there might be people in this room that are part of that trial, where we don't have the data yet. So this is an interesting possibility and suggestion that this might work, but the confirmatory trial is going on right now. And one of the things people do after these small trials is they try and see, are there any subgroups within the trial where maybe it worked a little bit better? And these are always dangerous because there aren't, you can sometimes fool yourself into seeing random patterns. And so this is something also we'll have to wait until we get the larger trial results. But this suggested that maybe there was a larger effect on patients in terms of their distant metastases rather than local recurrences. And if that was true, that would be really significant because distant metastases are the most serious thing that can happen in this situation. The other thing they did is that they did a measurement of how much burden of disease people have with this still microscopic disease that you can't see on a scan by looking at circulating tumor DNA. And so that's a measurement. Somebody who has detectable circulating tumor DNA after surgery for stage 3 melanoma probably has a little bit higher burden of disease than people who don't. And what they saw when they drilled down to those two subsets was that the people whose disease was the smallest that couldn't be detected by circulating tumor DNA, those people might have had a clear benefit from the vaccine. The number of people where there was circulating tumor DNA that was measured, so they have a little bit more disease, there weren't really enough of them to make a big conclusion. One of the important things whenever we're adding something onto an existing treatment is, are we causing more side effects? And the answer is a resounding yes, although you could argue that the side effects were not surprising and we hope transient. And so these people were getting effectively what was a COVID vaccine in addition to getting, regularly getting a COVID vaccine. And people in the room who've gotten a COVID vaccine know that that causes symptoms. It causes your arm to be sore. It can cause you to have a fever and fatigue and some of these other things for several days afterwards. And of course, they saw that in this trial. In addition, there were more frequent side effects of several types that were attributed to the PD-1 inhibitor rather than the vaccine. Meaning maybe there's some synergy feeding in here and that this definitely was harder to tolerate than the PD-1 inhibitor on its own. And about 15% of people in the clinical trial who were getting the vaccine stopped early because it wasn't something they wanted to deal with. One thing that we didn't see in this clinical trial was a higher incidence of the itises, the autoimmune attack on one particular organ where we can really pin it down, which is a reassuring sign. We also have a clinical trial here that's ongoing where we're trying to use a personalized neoantigen vaccine in the more advanced disease setting, where people have metastatic disease that's progressed on immune checkpoint inhibitors. And now we're trying to add the vaccine on top of that to try and help patients who didn't respond to first-line therapy respond. And so people enroll in the trial, they get a biopsy. It takes about 3 months to make the vaccine, and during that time, they get another treatment, sometimes on another clinical trial. And then we give people the vaccine in combination with a PD-1 inhibitor for up to 6 months. And one of the things we're doing a little bit differently in this trial is we're giving that inflammatory signal more often. So we're giving the vaccine once a month, and we're giving the inflammatory signal once a week, which means that people are getting the side effects from the inflammatory signal a little bit more often also. And I can't talk about sort of the real results of the trial because it's still ongoing, but we have seen some objective clinical responses. We've seen evidence that we're activating T cells. We've seen evidence that there's activation of immunity within tumors of these patients, even some of the patients that didn't have responses, and that the T cell responses include T cells that are attacking the antigens that we're vaccinating against, but also T cells that are attacking other antigens that we're not vaccinating against. Because one of the things we're trying to do with these treatments is not just to provoke an immune response against the vaccine antigens, but to try and cause a virtuous cycle where we get more T cell responses against other things as well. And then the last thing that I want to say is that we've been focusing on personalized antigens, ones that are unique to a given patient and very unique to the tumor. But there is another class of antigens that T cells can recognize in melanoma that are shared between patients. And these are normal proteins that are either expressed more highly in melanoma or that are found in related cells like melanocytes. And so there might be some people in this room who've received immune therapy for melanoma who've gotten depigmentation of the skin or vitiligo. And this is from T cells that cross-react with your normal melanocytes that give your skin pigment. And there is a thought that maybe we might be able to build vaccines that target some of these, and that we would be able to give them to people faster. We wouldn't have to go through this period of synthesis, but there are trade-offs to that as well. And so to summarize, melanoma tumors are recognized as foreign by T cells in the majority of patients with melanoma. And what's recognized as being foreign is mostly things that is specific to a given patient and not shared between patients. Your T cells that see your tumor aren't going to see anybody else's tumor. And that cancer vaccines are designed to increase the number of anti-cancer T cells, possibly also to boost their function. They require genome sequencing and they take time to make. And we have the best evidence right now, although not completely proven, that this could help prevent recurrence in stage 3 melanoma, but we await the confirmatory trial, which is ongoing and hopefully will have results in the next year or two. And then we have a clinical trial that's going on right here for stage 4 melanoma patients that have not responded to other treatments. And we're in the process of sort of learning more about that and seeing how people are doing. And so with that, I'd like to thank the organizers for giving me a chance to talk, and the Melanoma Research Foundation for being involved in this, as well as giving some funding for the research in my lab. And so I'd be happy to take any questions.
Has any of your research or research that you know of in melanoma been impacted by the recent changes in the NIH and the funding?
Not yet, and hopefully not in the future, but we're all apprehensive about that.
I bet, and probably everyone here too,
yeah,
of what's going to happen or happening with cancer research.
Yeah, there isn't anything changing there. Yeah.
Does the vaccine, is it applicable to brain metastasis?
Yeah, I mean, I think that's a good question. I think that there are definitely some cases where we think that activating the immune system is something that can work in the brain too. Our specific entrance criteria for the clinical trial requires brain metastases to be sort of under control. But we think the immune system can work in the brain too, although, sometimes not as well as it works in other places.
Please tell me, how many people was involved in the vaccine, personalized vaccine treatment? How many people total?
So in the trial that's been published, it looks like it was about 120 or so. In the trial that we've run here so far, we've treated 10 patients.
I'm sorry, how many?
We treated 10 patients in the trial here, and the trial that I discussed with the mRNA vaccine was about 120 patients.
120. Thank you.
Hi, you mentioned that these studies are related to sun-exposed areas, melanoma. Are there also studies like this for the non-sun exposed or the, I don't know, weirder?
Yeah, so I think the melanoma to some degree that happens on non-sun exposed areas, and so I'm talking sort of about acral melanomas on the palms and the soles, as well as mucosal melanomas. We do think that they still have an immune response to them, and in our clinical trial, we're still enrolling those patients. We do think that they have fewer mutations, and so what T cells are seeing in those patients might be a little bit different. But we think T cells are still seeing them. One thing that's been difficult is it doesn't seem that T cells see ocular melanoma as well. And that's something we're working on too. I don't know.
If there is a hereditary melanoma within a family, is the genetics very similar enough that you could actually give a vaccine prior to somebody who has very high risk of melanoma because of family?
So I think that that's something that's a little ways off. I think one issue that we have is that a small minority of the genetic changes that can happen are seen by the immune system. And so there's a good chance that the particular genetic change that's driving that melanoma might not be seen by the immune system. There are people trying to develop these sorts of, trying to figure out if there's some unique signature of those cells that you could vaccinate against. And so it's not a never kind of thing, but we aren't quite there yet.
At the beginning, you showed that vaccine research on viruses and melanoma affects similar parts of the body. And then you said that mRNA vaccines were tested with melanoma treatment. So are these two kinds of viruses and melanoma, is the research converging? And how did you discover that mRNA was more effective with the type 3 patients?
So I think what people have been doing for a long time is trying to, so maybe I can say a little bit about how, in my opinion, how the research sort of worked on this, is that people have been trying to make cancer vaccines work for a long time. And the companies that were working and the scientists that were working on that were trying to develop new and better vaccines and be able to make them more quickly. And then it turned out that one of these vaccine platforms ended up being very useful in a virus because, before COVID, we didn't have mRNA vaccines for viruses. And so I think there is cross-pollination between the research in terms of developing vaccines. And to some degree, mRNA vaccines were developed for cancer first before they were developed for viruses. Thank you.
Okay, that was very informative. I liked those graphics. I might have to use those in clinics sometime. So our last talk before lunch, also very excited to introduce Dr. Namrata Singh, who is a rheumatologist in our rheumatology division. Dr. Singh and I met, we both started here almost at the exact same time, and we met within like the first month that we started, which was before COVID. And she has been a remarkable leader. Some of you may have met her in clinic, but she has really become a leader at our institution in managing musculoskeletal side effects from immunotherapies, and she'll talk about that today. She's a part of several nationwide immune-related side effects efforts, and is really a leader in this field. She also is, as I'm sure you'll appreciate, very energetic and fun. I'm looking forward to her talk. So, Dr. Singh, please, welcome.
You can hear me okay? Great. Thank you, first of all, Evan, for inviting me. I'll admit to you that this is my first patient symposium, and I was super excited when I heard about this. And I came with a lot of enthusiasm, but the questions you've been asking to the speakers ahead of me, I am intimidated now. So with that in mind, be gentle. But hope I can share with you the things that I do in the clinic every day. And we'll go from there, and want to leave a lot of room for questions. So stop me wherever you want to stop me. The outline I created for today is to, first of all, talk about what are the rheumatologic or rheumatic IRAEs. And, this is toxicities have been touched upon from the very morning today. And IRAEs is a way of saying immune-related adverse events, or specifically toxicities of immunotherapy. And I want to go over some of the efforts we are doing at the UW for rheumatology oncology patients. And a lot of times I tell my friends I'm a rheumatologist, and I get the most blank look I've seen, in ages. And they're like, what does that mean? And then they go like, are you a dermatologist? So I'm like, no, I'm not a dermatologist. I'm a rheumatologist, and just wanted to go over what a rheumatologist is. And by the NIH definition, we are people who specialize in treating patients with arthritis and immune-related diseases that can affect the bones, the joints, or the muscle. So with that, diseases that affect them are called rheumatic diseases. So with that background in mind, also, again, I apologize. I feel like sometimes our notes, our language every day is so full of abbreviations. So I apologize in advance, but I wanted to make sure I shared the abbreviations, some of them. The DMARDs is drugs that we use to treat rheumatic diseases. Rheumatoid arthritis might show up as abbreviation as RA. RDs for rheumatic diseases, and of course, what I just talked about, IRAEs. So let's talk about a few rheumatic IRAEs that we see. So first of all, the one thing to keep in mind in the clinical trials, that if you were to look at of all the immunotherapies that patients received, very, very underreported in terms of the rheumatic, like joint pains or other side effects that patients might have experienced. At the same time, what is really, really more commonly reported is the term myalgias, right? So anytime you see algia, it's pain. So it could be myalgia, which is muscle pain, or arthralgia, which is joint pain. They were the two most common reported rheumatic IRAEs. But then if you were to look at the whole gamut of what could a rheumatologic IRAE look like, this is just showing you the spectrum here. So I want to start with the top, if I can make sure I get okay, I'm going to use this if it works. So, okay, so you see the sicca symptom here that I'm pointing. Even though, it's not the most common thing that comes to your mind when you're thinking rheumatologic, because it's not your joint, it's not your muscle, it's the glands that make tears, the glands that make saliva to keep your mouth moist, that can be affected with immunotherapy. And some of the most challenging, symptom that I've had to treat is the sicca symptom, because it's like, it gets so hard that patients have trouble swallowing pills. So that's something I wanted to make sure is appreciated and I appreciate totally, is the sicca symptom. And then the things I mentioned about before also is the myalgia, which I'll talk about, is muscle pain. And I'll go over a few. Rashes can happen because of rheumatic diseases. Kidneys get affected. Arthritis we'll talk about. But I think just to go over a very basic term, just something that when I am seeing a patient, or you'll see in your chart, written, is the very, very difference between the two words, arthritis and arthralgia. And I know all morning we've stressed upon you the itis, right? Like, there's anytime we see inflammation in a organ, we call it arthritis, hepatitis, colitis, depending on where that organ is. And a rheumatology mom's life, I'll tell you a quick personal note, is I have a 10-year-old who's very, very observant. And the past 2-3 years right now, we've been doing so much Zoom. So I've given a lot of talks from my office at home, and they hear things. And they now know what arthritis is, of course, right? So one, and they understand the itis term. And they've coined a term. My 10-year-old has coined the term motheritis. So that's the buzzword that the older tells, bro, don't go downstairs. Motheritis is happening. So just so you know that, so that just gives you the gravity of arthritis and the itis that we use. This just a very widespread language that we use in medicine. So hopefully you're not having a motheritis day, but arthritis and arthralgia. Arthralgia is the lack of inflammation symptoms. So there is pain in the swelling and pain in the joint. I'm not minimizing. Pain can be so bad. There is pain. That's why there's arthralgia. But they don't necessarily have warmth to the joint. They don't have swelling in the joint. And arthritis is the presence of swelling, warmth, redness in the joint. And then similarly, just to give you a snapshot. So on the left, right here is the normal joint. In the middle is osteoarthritis, which is a very, a disease, so to say, very common. All of us in this room either have it or they're gonna get it. There's no escaping it. So osteoarthritis. And then the rheumatoid arthritis is a more inflammatory or autoimmune disease. Not all of us in this room are gonna get rheumatoid arthritis. So just wanted to tell you a little bit of what is the difference. So the normal joint, of course, as you can see, between the two bones, you see the space here. That's and then this white part on both bones is the cartilage. That's the very, very important part that we need in our joints. Then there's this joint capsule, making the joint space, and then the two bones that are making a joint in this example. What happens with osteoarthritis is where, as with chronic use, the cartilage gets thinned out. The two bones that have supposed to have a space in between them, now they start rubbing on each other, and that's gonna hurt. That's osteoarthritis. There's no inflammation in the joint. But rheumatoid arthritis, now if you see, they have blown up this joint capsule. There's inflammation, and there can be damage to the bones inside. So they're not necessarily touching each other, but they're getting damage from the inflammation around the joint. So that's the big difference when I see a patient. Rheumatoid is just one way of depicting it as inflammation arthritis. The big thing when somebody comes in the clinic to talk to me about, okay, Dr. Hall gave me immunotherapy and now my joints hurt. So the big thing I want to talk about and figure out when I'm talking to the patient is what are the signs and symptoms they are having. Are they having arthralgia? Are they having arthritis? Or it's a completely different thing. Like, do they have muscle ache? Do they have, I'll talk about different things that make up the structures around the joint. So again, just to emphasize, arthritis, there's joint pain, there's reduction in the range of motion, that decreased physical function that Evan mentioned in the morning is coming from arthritis. The swelling is there, skin discoloration, it can look warmer, it can look red. And then, of course, when you touch the joint, it will hurt. And then there could be heat or warmth in the joint. So with that in mind, again, just to re-emphasize the osteoarthritis and rheumatoid arthritis, I might go into some of these more symptoms if you want to discuss later. Maybe if the patients will have the slide deck and everything. So it's in the slide deck. I won't belabor this some more. Now, the one other structure I wanted to talk about is this term. I don't know, again, if you've heard this before, but enthesitis. So the one thing, basically what I'm trying to say is the joint pain happening. My knee hurts. It's so much more. I have to figure out, is this the muscle around the knee? Is it the enthesis around the knee? Is it the joint itself? Or it's just something else. Sometimes patients have blood clots, and blood clots can give pain in the leg, and it can hurt like, oh, my knee hurts, but it's actually a blood clot under it. So things have to be kept in mind. Now, what happens is this muscle is what I'm trying to show here. When it attaches as a thin ligament coming down here, and it touches the bone, that's what's called an enthesis. So that's where a ligament attaches to your bone, and that can also get inflamed. So patients can get enthesitis. So there are different things that can be going on to drive somebody's joint pain. Now, what types of arthritis do we see when patients come in the clinic from and have had exposure to immunotherapy? So these are the big three patterns. One is called polymyalgia rheumatica light. So these are names that we as rheumatologists were already managing. Of course, as you can imagine, this entity of immunotherapy arthritis is more since 2011, right? Like when I was in medical school, there was no immunotherapy. So there was no immunotherapy arthritis. But these are de novo diseases. Polymyalgia rheumatica, we've treated for several years. So we are just trying to see what pattern somebody's arthritis might fit that we are used to trained from the beginning to see. So polymyalgia rheumatica is one type of arthritis we see. Sometimes we see a very symmetric. So like both the knuckles on both hands hurt, both knees hurt. So it's very symmetric. When it happens very symmetrically, we tend to think more like rheumatoid arthritis pattern. If it's like asymmetric, okay, my right knee hurts, but my left ankle hurts, so that could be another arthritis type. So again, these are just terms in terms of what me as a rheumatologist communicating to my oncology colleague, and eventually I might, like, let's say patients, change cities, change towns, you go to another rheumatologist. This would be a language that I'm using to communicate to the next rheumatologist, for example. The few things as a patient that I always emphasize when I'm diagnosing somebody in the clinic with IR arthritis or inflammatory arthritis from these drugs is that it will persist after immunotherapy is stopped. So, we've talked about this on and off switch with the immune system, right? Pretty much what was happening is there were breaks on your immune system to say, this is your own body, don't attack it. Then comes immunotherapy. We take off the brakes. We want go kill. They want to go kill the tumor cell. Sometimes that self and non-self gets the immune system can only do so much. Then they see, oh, this knee is here. I'm going to go attack it. So that's where the immune arthritis happens. Now that break once has been taken off, just like your hormone, the glands we talked about, this doesn't necessarily stop. So if you might come and say, okay, Dr. Singh, now I've told Dr. Hall, I'm not going to take immunotherapy. What do you think? Can I stop all my treatment for my arthritis? Sadly, the answer is really, we will hope in the few months or years from now, but it's not an immediate. I stopped pembrolizumab yesterday. Today is not like my arthritis is gone. So that's very important to understand. The second bullet also going that, unlike the colitis or lung inflammation, this usually persists. And then the third thing, though, at the end of the day, there is a silver lining, right? Because we think your immune system got all awakened and is maybe attacking your joint, we think there might be silver lining that your immune system is doing exactly what we asked it to do. It's killing the tumor cell. So most of my patients with immunotherapy-related adverse event might have a good tumor outcome as well, like initially what they got the immunotherapy for. So then the other thing I wanted to touch upon is the myositis, which is muscle inflammation. So a lot of times that's more pain in the muscle, but more than that, weakness. So it's like difficulty getting out of the bed, difficulty, combing your hair, difficulty getting shirts on. That's could be either arm weakness or going up and down the stairs. because of weakness in the thigh muscles. It's very rare. It's a much, much rarer. But the problem is we want to recognize it early because it's the one thing that can be very, very harmful if we delay the diagnosis and treatment. And then the other thing that we don't know, I don't know the answer, but these are different. I don't know if you've heard of the terms myocarditis and myasthenia gravis. These are other two autoimmune conditions that I've never, ever seen in my life happen in a patient with myositis. But for some reason, this is the way their immune system gets triggered, that we see a lot of these three overlapping. That's the other thing I need to make sure we emphasize our patients is with myositis is we need to screen you for myocarditis. We want to look at your heart. We want to look at your nerves and want to make sure that there is nothing else going on. I don't care at the time. If they have myositis, we are checking them for everything in terms of these two other conditions. Now, vasculitis, this is a much rarer, even rarer than myositis, is where vessel is all the plumbing of our body, right? So the arteries and veins that take and bring blood back to the heart, those can get inflamed. So vasculitis can also happen, and again, can range from all the way from 3 months to 18 months after immunotherapy, and sometimes even delayed onset. So with that in mind, I'm going to switch gears and talk about what are the rheumatology IRAE, things that we are doing at the UW. So first of all, one thing we do here, we have people call it differently. It's a rheum-onc or an rheumatology IRAE clinic. It's one of like if you or your caregiver needed, you wanted to see how do I get established with the eye. Of course, your oncologist is your, the door to that clinic. But one thing to do is if you were to Google Rheum IRAE clinic, this menu should pop up in a Google search where we have our specialty clinics. So because our diseases in rheumatology, they always cross systems. So they can affect the skin, they can affect the kidney, they can affect the lung. We have a lot of multi-specialty clinics. And with that in mind, we now created the Rheum IRAE clinic. So that should be an easy Googleable, if that's a term, Googleable clinic to find. The way it goes is your oncologist can put in a referral. Usually it's housed on a Monday afternoon. There's a schedule, but we add on patients as needed, somebody who's needing urgent analysis and everything. And a lot of trainees come through the clinic and rotate so we can keep training the next generation of trainees so we can, have future also taking it into account. The second study that we are doing is to understand, I showed you that joint space, right? That what does that joint happen? So if you were to ask me today, like, what's going on in my joint? Why do I have this arthritis versus the 3 other people I was in the room with who got immunotherapy don't have it? I don't necessarily have a great answer for you, but I think at the end of the day, we want to see where the action is happening, right? Where is the inflammation is in your joint. So we have a study going on in collaboration with my colleagues here, Dr. Pollack, who does ultrasounds, and Dr. Buckner, who's at the Benaroya Research Institute. So the idea is we are collecting patients' blood samples when they have, after consenting them, they have arthritis from immunotherapy. We get the ultrasound images. If they agree, we get the biopsy. And then the idea is look at it under the microscope. What is making it different? What is going on with their immune system? Why did they have this arthritis? So this is a study that's ongoing, and we've been recruiting patients to this since 2 years now. The third one is funded by the NIA, and whoever was asking questions about funding, well, yeah, probably the worst times to be in, but right now, this study is ongoing to my knowledge. And what we want to study is, this is not just about the patient with immunotherapy and arthritis from immunotherapy. We've been treating patients with like rheumatoid arthritis, psoriatic arthritis, etc., who can go on to develop cancer, right? Now, what do we do? These are patients who already needed immune suppressing drugs, and now they've gotten cancer, and now the balance, right? Like, how much immunoboosting I do, how much immune suppressing I do. So this is another study we are, looking at the UW. And then this is an last effort I wanted to mention is the Radios Registry or Consortium. So this is multi-center, multi-center study where, because if I told you, because we did something in 5 patients and this is our data, we might probably have, I myself might be like, okay, I need to know this if this is true for more patients, right? Like 5 patients might not be enough to say, this is what happens with this therapy or clinically. So this is multi-site. We are 12 people, 12 institutions at this time. It's housed coordinating centers at Hopkins, and we are, enrolling patients at each site who have immunotherapy arthritis, so we can put our brains together and understand what are the patterns. Can we say who's going to develop arthritis from these drugs? And once they develop arthritis, what's the best treatment for their arthritis? So I really, really think multi-center studies where we can pool our data is really the way to go. And what do we have so far? And this is a few months outdated now, but as of November last year, we had immunotherapy arthritis, a total of 658 patients, of whom 384 had arthritis, and different studies are in the pipeline to be released this year. So hopefully we understand more and more with efforts like this. With that in mind, I think some other examples we had of management for immune-related adverse events and what are we doing. But I think in the interest of time, I'll stop here and would rather open the floor for discussion. And thank you for your attention.
I promise she'd bring the energy. I don't think she disappointed. Great talk. I will just tell you, a lot of doctors don't understand the difference between arthritis and arthralgia. I see it in notes. You've given me a refresher. I feel confident now, but this is really important, and you can see how they're very important to distinguish. So thank you for a very enlightening talk. We'll open it up for questions. It's crystal clear. I'm kind of tempted to ask, oh, there's a question. Great. I was gonna.
You mentioned the Sika, I think it was, you showed the mouth.
Yes.
Does it occur in other mucous membranes, say with the glandular cells in the mucous membranes?
Yeah, so we see the dry mouth. We definitely also see decreased tears. So there's a lot of dry eyes that we see in our patients.
How about in the intestinal tract, like the stomach and stuff?
That's a good question. I don't think I'm aware of or have seen a lot of cases of this, but it might be we haven't put the two together. Is a possibility for sure. Great question.
We do.
Yeah.
Inflammation of the stomach or the small intestine or the large intestine, or even in the mouth, stomatitis or irritation there. But yeah, I think. Oh, sorry. We do see those. They often are managed by our gastroenterologists we have actually oral medicine at the cancer center, a group of dentists that are focused on cancer and cancer complications, and they help us manage the mouth ones, but we do see that.
Yeah, so I'm gonna bring up the question before. So for a person that already has arthritis, okay, not algia, is there any information on how the immune therapy affects this? Does it make it worse? Is there any effect on it? Prior to finding the diagnosis of my cancer, I was on an immune drug from my rheumatologist, who, of course, my brain doesn't remember that much anymore. But it was, there's a question of whether or not that promulgated the development of the melanoma, and we just basically stopped that treatment. So again, for the period of the first year or so, I stayed away from all anti-inflammatory drugs, and I paid the price for it. So again, back to the question, is there a way to quantify, how much of this has gotten worse because of this, or is it just the disease? I don't know if you.
Sure.
I don't know if there's information.
Brilliant question. Thank you for raising it again. So I think we have a few studies that have looked at patients who already had a pre-existing autoimmune disease. And after immunotherapy, the statistics would say 50 to 60% of patients will flare if they stop all their treatment for autoimmune disease. So there's a good chance that your disease will flare. But if we had a very low disease act, so if your disease was already very well controlled when you started the immunotherapy, that can be on the lower end of the flare. But good news is if patients flare, we can get them back on control the disease very quickly. But of course, it does involve instituting whatever immune suppressing drugs or immune anti-inflammatory drugs they were on before. So that's one part of it. And then the second question is, not all immune suppressing drugs are the same, right? Like the steroids, 60 milligram versus 5 milligrams of prednisone, or, these drugs we see ads on the TV for Humira, Enbrel, et cetera. Not everything is created equal. So I think the idea is we work with the oncology team, we work with the patient and make sure that whatever data suggests is the safest drug in the setting. So again, melanoma is very different from renal cancer. It's very different from lung cancer. So there are so many things we have to take into the equation when we are talking about what drug to give for your rheumatoid arthritis. But not all drugs have to be stopped necessarily. In fact, there are so many studies that I didn't go into today, but there are some studies where one of these drugs called Actemra or tocilizumab. It's a type of drug that blocks one of the immune molecules that we think causes inflammation. It's being tested right now with nivolumab, with pembrolizumab. So patients are getting their cancer treatment, they're getting tocilizumab, they have no immunotoxicity. The idea is to see, will this prevent toxicity to happen? So one arm is getting 2 agents together, the other arm is just getting the oncology drug. And the idea is to see, will there be less side effects now that we preemptively treated it? So I think, of course, very highly anticipate those trials results to come out, and we'll have more information in a couple of years. No, that would be that's something we would recommend for osteoarthritis, but honestly, in the last 5 to 10 years, the data on hyaluronic acid has been very, very low level. So it can be very temporary relief, but it's not a long lasting answer. And no, not being studied right now in that trial.
I think as we head towards lunch, I'm mindful of where we're going. I almost want to say a show of hands. Anyone been on or knows somebody who has been on prednisone? Yeah, okay. So it's our long-standing immunosuppression. It works for all the itises. It is a giant wet blanket for your immune system. And Dr. Singh and her colleagues in rheumatology are really leading the way on how do we more specifically calm the immune system down so we keep the good stuff happening, but address the side effect. And so a lot of those studies they're leading are going to help us do that. So we become a little more precise about how we manage these side effects rather than a giant slug of prednisone for everybody, which is still something that happens in my clinic pretty regularly now, but I think 5 years from now will be different. One more question and then we'll go to lunch.
Impact the efficacy of immunotherapy?
Yeah, and I can start the answer, Evan. Please feel free to chime in. I think really at the first thing is if we can avoid it, great. That would be the best scenario. But when we need it, the lower the dose that we can get away with, the better is always the approach that we take. So 60 milligram we think is very, very against your tumor, but also depends on the duration, right? So dose and duration both matter. 60 milligrams for 2 days versus 60 milligrams for months. Are we talking 10 milligrams for a few weeks? Or are we talking 10 milligrams for years, right? So short term, moderate term, long term side effects pile up. At the end of the day, the lowest that can control the symptom is probably the dose you want to go with. 10 or even 20, I think, is the data that shows 20 and below is usually relatively safer compared to higher dose. And the other thing to mention with steroids is there are studies that said early start of steroids, early meaning when you started immunotherapy. So you started immunotherapy, soon something happened, you got a lot of steroid, that's usually bad. So if somehow the steroid start can be delayed 3 months or later, usually is better results. But at the end of the day, lowest possible dose.
Yeah, great question. We're really worried about this originally, that, at the same time we're trying to get the immune system to attack the cancer, we're just snuffing it out with prednisone. I think the question is always, why does someone need it? So the immune system can make you very sick, as we've heard repeatedly this morning. So it's about safety. And then really the timing. Are you on prednisone when you start immunotherapy? That is difficult. I use the analogy, start a campfire in a rainstorm. If you're already on a bunch of prednisone when you need to start immunotherapy, that's hard. If you're on it and then you have a big immune activation, the immune system's gone, like it's doing stuff. So we're a little more comfortable using steroids to manage the toxicities that arise, because the immune system's the switch has already flipped. It's happened. Now we have to, keep it from harming the body and keep people feeling well. So that timing question is really important. I think the data actually suggests there's some limitations to the data, but appropriately managing the immune side effects does not seem to jeopardize long-term cancer outcomes. So that's an important takeaway. That said, prednisone has lots of other complications, so we try not to use it for longer than is needed. Yeah, great question. Let's have some lunch.
You and Lance.
Those studies stratified out the amount of tumor volume, tumor burden.
That is something we do.
Yes.
That's so great to hear. All right. We're back from lunch. Hopefully people are full and ready for the second half of the program, because this is where we get to hear from patients and caregivers themselves in the afternoon. This is usually I think it's pretty hard to beat. So to start off the afternoon section, it's my pleasure to introduce Debbie Churgai from Melanoma Research Foundation. This event is a collaboration with the MRF and has been since long before I started being involved. So they are instrumental to our ability to have this event and put this on every year. And they have a tremendous amount of impact in developing educational material for patients, people that are diagnosed with melanoma, funding melanoma research, and really involved in just about every element of advancing melanoma care. So it's my privilege to introduce Debbie, who's the Education Program Manager at MRF. And thank you very much for being here today.
I'm just going to talk to you a little bit about the MRF. We've had a few people come and ask us questions out there, and so hopefully I'll get most of your questions answered. First, I just want to say thank you to our sponsors. So this event that you're at today is, we could not do without these sponsors right here. In fact, if there's any representatives from the sponsors, can you just here? There we go. There's one back there. There were a few others here, but if you see a representative, please thank them, because it's because of them that we are able to put on events like this for you guys, and Fred Hutch as well. The Melanoma Research Foundation is the largest independent organization devoted to melanoma. We're committed to the support of medical research to develop effective treatments and eventually a cure for melanoma. The MRF also educates patients and physicians about the prevention, diagnosis, and treatment of cutaneous melanoma, and also the rare subtypes, including ocular, mucosal, pediatric, AYA, and acreal. The MRF is dedicated to advocate for the melanoma community, helping to raise awareness of this disease and the need for a cure. The MRF website is a premier source for melanoma information seekers, and we definitely encourage you to check out our website if you have not already. I'm going to go through some of the things that you can find on that website. So MRF was founded in 1996 by Diana Ashby, who was diagnosed with melanoma after a 3-year battle, found that there were no options for new therapies in clinical trials. This picture of Diana and her husband, Captain Jeff Ashby. Diana's legacy lives on through the MRF and the incredible work that we do to help accelerate medical research while educating and advocating for the melanoma community. The MRF consists of 3 pillars: research, education, and advocacy. The symposium right now that you're at is a part of our education pillar. And we work with different partnerships, different cancer centers across the country to put on these events for patients and caregivers. And I'll be sharing some of our many other educational resources in this presentation. A little bit about our footprint today. We host several events all over the country, including 19 5Ks in different cities. In fact, some of you, most of you, if you got one of these folders, there is a postcard. We are having a 5K in Seattle on October 4th. If you haven't been to one of these events, I definitely encourage you to go. They are amazing for the community, and we raise a lot of funding to do research. Again, if we have them all over the country, and we also host 2 galas each year, one in New York and one in Denver, if you're interested in attending. We also bring patients and caregivers to DC to advocate for more funding, melanoma research, and to talk to legislators about why this funding is critical for melanoma. We also host 6 patient symposia, like you're having here today, across the country every year. And one of those is also, we have to do one more that's focused on the rare subtype community. This is just a snapshot of some of our research, which we have funded in the past and are currently funding right now. We have awarded over 31 grants in 2023 and have funded over $25 million of research. And that number is likely to increase quite a bit this year. We have a variety of educational opportunities, and those are not just for patients, but they're also for caregivers, family members, providers. Our educational program includes educational literature, webinars, animated patient videos, patient and caregiver symposia series, rare subtypes, and more. We have 26 pieces of educational literature available. In your folders is just a few resources, but I wanted you to know we had some on the table too that kind of, unfortunately, we don't have any more of those on the table. But we have a lot of different types of literature. All of them are free to download or order. So if you're having an educational event, you can order 100 of the more melanomas to give to your family and friends, or anyone that you think might be interested in learning more about melanoma, helping to educate, spread the education. But we have them on all sorts of topics: cutaneous, OM, mucosal, pediatric, clinical trials, TIL cell therapy. We have lots of information. We also send these to physician offices and dermatology offices all over the United States. So if you want to get some for your dermatologist or your oncologist, you know, we can do that as well. We currently, these are animated patient video series. We currently have 6 modules available. However, we are working on 2 more. These videos, they're all less than 10 minutes long. And if you have family or friends who want to learn more about melanoma, I always suggest these videos because they keep you interested. They're animated, they're educational, they're pleasant to the eyes. They're an amazing resource that we have available. All of our videos can be found on the MRF YouTube page. These include over 64 on-demand videos, including this patient and caregiver symposia will be available on our YouTube in a few weeks, but also all of our past symposia and all of those presentations are available. Webinars we have available, and there's an educator course, all on our YouTube channel. We have the Ask the Expert webinar series. So we host about 1 webinar a month on relevant topics to bring to the patient community. And so that they can interact with experts. So the webinars usually include an expert and a patient because we want to kind of hear both sides of the issue. And if you're interested in participating in a webinar, or if you have ideas for a webinar, I encourage you to write those down in the survey or to get in touch with me so that we can have some ideas for the upcoming months. Conversations include, we have a patient and community forum on our website. Conversations include a range of topics such as new therapies, rare subtypes, and how to handle grief. This is a great resource for patients or caregivers where you have a question about something and you just don't know who to talk to about it. This forum has been going on for years, and so there's a lot of great information on it. You can search if you're looking for something specific, or you can start a new conversation. As I mentioned before, every year we bring patients and caregivers to the Hill to meet with congressional leaders. We also work with legislators and policymakers to help increase funding for cancer and specifically melanoma research. We just held our annual Advocacy Day last month, but if you would like to attend our Advocacy Day next year, please reach out to me and I can connect you to our advocacy director. And I know a lot of you have been, I heard a few of you already asked this question in a previous presentation, but I know a lot of you are wondering what's going on with melanoma research, cancer research in general, with everything that's going on. And I just want to let you know that the MRF has been monitoring ongoing developments within the federal and state governments. And we are engaging our advocates on issues ranging from sunscreen filter approvals to federal research funding. We will continue to work with lawmakers in order to continue to advance the prevention, treatment, and research for this deadly disease. And if you can, there's a QR code. You can scan the QR code and stay connected to the MRF's advocacy efforts. Or, as I mentioned, please get in touch with me if you're interested. We have several prevention and awareness campaigns. Our spokesperson last year for our Get Naked campaign was Miami Dolphins running back Raheem Mostert. Our new campaign spokesperson will be announced in May, so keep an eye out for that. We also have our I Get Dilated campaign for ocular melanoma. We have Spot the Dog campaign for pediatric melanoma, and we have Out of the Shadows campaign for mucosal melanoma. We also have several programs we support, such as the MRF Breakthrough Consortium and the Mucosal Melanoma Initiative. And all of these you can find out more about on our website. If you do happen to get Cancer Today magazine, the MRF educational resources are featured in this month's issue of Cancer Today. Normally I would have a pack of them on our table, but unfortunately they did not arrive in time. So there was a one pager out on our table that had the ad. But if you do get the magazine, please check it out and explore all of our resources on our website. And in case I haven't mentioned it, the MRF just currently went through a big rebrand. So if you see two different logos on things, that's because we are currently switching. This is our new logo. So, but if you happen to see the old logo, it's because we're just kind of right in the middle of switching things out. The best way to stay in touch with us or to find out what we're doing about educational events or other offerings, Advocacy Day, the 5Ks, is to join us on social media, to follow us on social media, tag us on social media if you're doing anything melanoma related. We're on all the big social media sites, Facebook, X, Instagram, LinkedIn, YouTube. Blue Sky? Oh, okay. Oh, yeah. And there are many opportunities to support the work of the MRF through a variety of programs and events, research and funding. In fact, if you haven't met my coworker Dave over here, if you are interested in helping us, especially when it comes to research and helping to fund research, being at these symposiums and you can see the new research, like I just think it's so cool that you guys can be part of that. You can be like, I helped fund that amazing research. So you can do that through us. Please feel free to reach out to Dave or contact myself or any of us on the MRF staff. We would be more than happy to help you find ways to get involved. And not just through that, but there are many other ways as well. Like I said, going to advocacy days or speaking, sharing your stories on our social media or at events like these. We appreciate your feedback. So in your, as you registered, you should have received a survey. And your input helps us to improve future sessions, but also develop new programs. So if you're able to fill that out today, and then you can drop it off with me on your way out, we would really appreciate that. We will also send you, I believe Fred Hutch will send you a link with the survey that you can also fill out online if you don't have time today. But we know that, while the information is fresh, it's always helpful to fill it out or fill out as most as you can today about each of the presentations that you heard today. And also make sure to tell us if you have some information that you didn't hear about that you would like to hear about in future sessions. Again, I just want to thank our symposium sponsors, Castle, Pfizer, Genentech, Iovance, Bristol Myers Squibb, Merck, Immunocore, Immatics, and Regeneron. These are all amazing sponsors that care about patient issues and gave us funding specifically so we could put on these events for you guys today. So big shout out to them and thank you. I also want to thank Fred Hutch Center. We've been doing this with them, as Dr. Hall said, for many, many years. It's a great partnership. We love doing it. And so thank you to Fred Hutch for partnering with us on these events. And that's all I have today. Thank you all for being here. It's on.
Okay, 4. I'm gonna give it. No, but you need to talk tight to it.
All right. Okay. So I'm really excited for this next presentation. I'm excited for all the presentations, but I really think our social work team are like some of the unsung heroes of our cancer center. They do a lot that I know I'm not even aware exactly of everything that they do, but we really get them involved when people are usually when things are not going according to plan and people are having challenges of many different types. So I am really happy that they exist. And today our two kind of social workers that we work most closely with in our melanoma program are here to give us a presentation titled ... and cancer beyond the diagnosis. So it's really exciting to welcome Alex Lee and Tracey Pierce for this presentation. Alex is newer to our institution, spent a lot of time in training and doing social work and mental health on the East Coast. Tracey's been around Fred Hutch in many different roles for many years, but has been a social worker on our team for the last several years. So welcome to both Alex and Tracey. Thank you for being here today.
Thank you. I think this works, yeah. Thank you so much. We're going to co-present, and we know that this is after lunch. And so we'll try to bring our energy as much as we can, but we're feeling the same as you are right now, having maybe eaten a little bit too much.
All right. Thanks very much, everyone, for showing up. So just a couple of things to make things a little bit more personable for this half of the symposium. My name's Alex. I'm, like Dr. All said, I'm alongside Tracey, one of the two social workers primarily attached to renal melanoma and sarcoma teams. I use both he and they pronouns. I'm Taiwanese American. I enjoy good food and sometimes traveling for the sake of good food. I play a pretty decent amount of Pokemon Go, and I might be running off to do that after this is over, so don't blame me too much. And I was also a caregiver of a parent and cancer patient for close to 8 years. I became a social worker in large part because of the challenges that my family faced when navigating a system that couldn't always support our lived experience.
And thank you for being here, Alex. I'm so excited.
Thanks, Tracey.
I'm so excited to have a coworker. I'm Tracey Pierce. As Dr. Hall said, I've been around Fred Hutch for quite some time. Most importantly to know about me is I'm a big fan of women's basketball and the WNBA, even though I'm only 5 feet tall. I live my best life. And talking about singing our praises, I sing really poorly, but love karaoke. And so we are all like just a series of kind of dichotomies all within ourselves. And what brings me to this role, this work, is the AIDS crisis. Go figure. In the 80s was when I graduated from high school, in the early 90s from college in New York City, in Greenwich Village. And I really believe that the inherent dignity of all people is a driving kind of motivation and factor for my work. And so here I am in my second life career. I'm also a 2-time cancer survivor. And so we're hoping in this talk to kind of give you both kind of sides of the experience as well as our professional experience. Oh, I forgot to ask you guys, how many of you, by a show of hands, are patients? Oh, okay. Thank you for coming. And how many are caregivers? Ah, awesome. Thanks. How many of you are Team Mariners? What? Okay. How about Team Red Sox? Oh, Team Yankee? Oh no, not a single other New Yorker. Okay, bear with me then. All right. Well, thank you for letting us get to know you a little bit better.
All right. Well, thanks, everyone. I think one of the things that is really important to us here in social work is getting a sense of who we all are outside of the experience of cancer. And so here we have kind of this notion that, I would probably say that I had before, coming on board as a caregiver, sort of with these assumptions that the way that people move through the system when it comes to getting a diagnosis and treatment looks something like this. So, people start by identifying some symptoms and feeling like they need some kind of referral, and then they get a diagnosis that leads to a range of treatment choices, which can then become cycles of therapy and any sort of adaptive changes in the care plan. And then on the right side, leading to survivorship and disease progression as possible results from that. And so for those of you thinking back to what it was like for you before coming into this close proximity to cancer, how many would say that this was kind of your assumption of how this model works? Yeah, that sounds like most of you. And so, but we also know that there's a lot more that goes on and influences who you are in this experience. So zooming out, we see all the ways in which all these social factors come together to impact the experience of patients and caregivers alike. So to name just a few of these, we can say that race, religion, histories of mental health, a sense of personal safety, a family history of cancer or dealing with the medical system, really concrete stuff like finances, housing, the ability to access reliable transportation to get to and from treatments. All of these have some impact on the ideal model of what cancer care can look like. And that can really complicate this picture, sometimes by being a barrier and challenge, and other times being a strength. But in addition to this, we also note that there's a lot of factors that aren't things that you can fill out in a checklist or kind of a text box format, that there are all these ways that people talk about their experiences, your internal strengths, your family, your friends, your neighbors, and the community groups that have come to support you as patients and caregivers through the process that makes this a lot more bearable. And so, as I think Tracey and I understand, we're all more than just itemized lists. And, it's important that we recognize that here in our profession.
Yeah, and so I wanted to zoom out a little bit to your experience before you became a cancer patient, and some of the words and the way you might have heard about cancer being spoken, things you might have read, metaphors that we use. This is from because I love research, because we were at Fred Hutch, British Medical Journal of Supportive and Palliative Care. And these are word clouds. So the research I'm going to show you is going to be presented in a word cloud where the words that appear most frequently in a study are going to be big and bold. And the ones that appear less frequently are going to be tiny, 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 and small. And so thematically, when we think about how we experience cancer, there is the patient's way of experiencing cancer and your medical healthcare professional's way. And the words that we use to describe your experience is very important. It helps us get to know you a little bit. So in this study, thematically, we were looking at in social media, in publications. And also we were looking at chart reviews. So like Dr. Hull, I think, or Dr. Veatch talked about is how do we document our time spent with you, and words that we use as well as healthcare professionals. And so compared to healthcare professionals, there's a lot of violence and journey metaphors being used more frequently. And we find that when patients use these types of metaphors, no matter how you feel about them, positive or negative, that they are about empowerment. They're about you taking action because they are all action words. But we don't have good ways of capturing uncertainty, helplessness, hopelessness, and other emotions that you might come up during your time with your doctor. And so these feelings of vulnerability really can speak to the need for framing cancer within metaphors, maybe more of gentleness and compassion. So this was one study. The next study is another word cloud and another study. And this was done in 2017. Oh, this was done of Reddit, subreddit. So we talked a little bit about social media and where do you all go for your information? Some people go to Facebook, some people go to Instagram. You might go to Melanoma Foundation, but a lot of people go to Reddit. And Reddit, I hope you all are familiar with Reddit, but basically there's conversations between people and you just go to like a subreddit for cancer. So this was about conversations about cancer pain. This was looked over 10 years of text, and it looked at the subreddit for just cancer at 679 posts over those 10 years to identify unmet needs and emotions related to cancer pain. And so as you can see, there's two sections, patients on the bottom, caregivers on the top. Patients frequently used, and this is in the Reddit, terms describing the physical aspects of pain, causes of pain. Can you circle the ones?
Oh, I don't
That's
think we
okay.
have that version.
Oh, we don't have that version? Oh, okay. All right, so the bottom parts. So you can see words like sore, scar, treatment, chemo, sensation, nausea. They're very physical. They're very pragmatic. On the other hand, if you look at the top, caregivers were very relational. They used words worry, scary, their roles, mom, dad, sorry, that was a really interesting one, care and help. And so you can see kind of the cluster of words that is not shown are the clusters of words that describe uncertainty. And those were the most frequent cluster, I guess, theme of many of the words that were used when both patients and caregivers. Yeah.
All right. So Tracy and I are both social workers. And I don't know how many of you have worked with social work before, but oftentimes when people hear the word social work, they think of something like child protective services. And so how could we possibly fit into this conversation around patient and caregiver experiences? Well, it turns out social work works in a variety of settings. Some of us you might find in schools or hospitals, skilled nursing facilities, and also here at the Hutch, joining you all alongside your cancer journeys as patients and caregivers alike. And so one of the reasons that we called this talk End Cancer is because we're really focused on these aspects of identity and story, the transformation that takes place as we move from a kind of pre-understanding or experience of cancer into a space where we've all been transformed by it one way or another. And some of these challenges of who we saw ourselves before this experience can be altered and shaped by cancer in ways that are really hard to describe. And so what we do here, one of our primary functions is to work with you around finding that language, uncovering those aspects that are really hard to speak about or talk about sometimes, and really bringing that into the conversation as well. Because we take this sort of 30,000-foot view, these sort of things in the cloud that you see here are all pieces and components of your experience. And we don't weigh any particular part more than another. We're not here to prioritize any single one. They all matter. So for some people in the room, maybe the economic challenges associated with cancer are more salient today than even a year ago. Or the psychological challenges. We've heard about some of the side effects that can come alongside some of the immune treatments, which I'm learning about alongside probably some of you today as well. And so we serve kind of three roles here. We are here as supportive counseling for patients and caregivers alike. And then for all these sort of like concrete things, we're really practical folks. So we get on the ground with you if there's someone denying you benefits or there's some kind of like issue that is coming up with regards to like rent or whatever, we'll join in that like very practical fight with you. And we are also members of your team as advocates, centering the values that you bring into this room and also into the clinic, understanding that the direction of treatment is something that is in line with what you want and isn't an agenda that is forced by all of us here. So, you know, we don't necessarily want to belabor that too much. And I think that there's going to be more conversation directly from you all, patients and caregivers, in a moment. But yeah, thank you all so much for your time.
With our time, like, are we done? Are we wrapped up?
Yeah.
We got 5 minutes? Okay, yeah, Dr. Hall brought up the idea of trauma and how sometimes the treatment that we provide to you is a stressor, right, in your life. And that ideally, right, some people start the journey thinking that when they end the journey, they'll just pick up right where they left off. And you are transformed by this process. And sometimes other people don't see the transformation. And they don't know how to think about us, and they don't know how to relate to us. And you might not even know a lot of times how to relate to your own body, your own mind. And so that is a good time to speak to us. We are free service. I just wanted to let you know, free. Free. Fred Hutch is giving you something for free. It's going to give you access to me. It also gives your caregivers access to us as well. So you might be doing fine because as you see from that little pain word cluster, you're like focused on breathing and getting up every morning. Your caregiver though, as we saw in that top word cloud, might be having stress and distress. So happy to chat with them. And then sometimes that flip-flops during survivorship, that kind of cliff, we talk about the survivorship cliff in social work, where you feel like your entire support system, Dr. Hall, you might be only seeing every 3 months, every 6 months, every 12 months. And so your support system in the medical community kind of dwindles. That's the time when we see a lot more depression and anxiety and the effects of the transformation, the stressors and the trauma in patients. So also feel free to reach out to us through the Survivorship Clinic as well. Any questions, anything you ever wanted to know about basketball?
When my husband went terminal, we chose hospice. Now I know that social work was offered to us, which we didn't accept. But do you work with hospice patients who were Fred Hutch patients? Because, you know, I did the whole caregiving all the way to his death. Also, I just want to say this. A lot of times when people hear caregiver, they think, oh, somebody is in bed and they're, you know, you're caring for, and that, my husband was active until 5 days before he died. So that's kind of a point I want to make too, but I was just wondering about and do you have bereavement support?
Great questions. Thank you so much. We did not talk about the duration of our services. Yeah, we're free. So again, you don't have to come here. I don't have to bill for you. I don't have to see you. I don't need a CPT code. I don't need an ICD-9 diagnosis, ICD-10. And so we frequently see patients up until the point where they want to stop seeing us. And that will include up to, through hospice care. The same with our nurses. Our nurses are free and they don't bill and they never, ever, ever will let you be hanging. And the second one was bereavement. Yeah, absolutely. Free, not billable bereavement services. I will work with complicated grief. I will work with regular grief. We will see you. Sometimes you just need 3 sessions with us, right? Just a kind of, there's normal grief and it's going to feel bad. And so sometimes it's nice to check in with someone and know that what you're going through is typical and within the expected range. And if it's not, I will tell you. and we will work together to find a way to either connect you to this community or stay with us. Anything to add to that?
No, that was wonderfully synopsized. Thank you, Tracey. This is what experience looks like.
No questions about basketball? I know, right? And so I'm missing it. But last night, so the women's finals, we have UConn, right? The Husky women versus, what is it, South Carolina? Yes, and Juju got injured, and so big takeout for USC, surprisingly.
I guess I'll just share something that resonated with me, not about basketball, sorry. Being in the room, a lot of attention, the doctors, the nurses, the staff in the infusion area geared towards the patient. Many times they're not the only one in the room. There's a support team. So I think the caregiver comment, caregiving, I think, does have this connotation of providing a lot of like minute-to-minute physical assistance, which is certainly something that can be required, but is not the only way in which a patient's support system helps them. But probably just being self-critical, like I don't think we provide enough attention or direction to the other people in the room. And that's one way in which in my own practice, I've found having Tracey, I'm very excited to have Alex, as another layer of support for the other people, which is not, again, like we have a patient and like that's very clearly a person who needs to be heavily featured, but they're part of a larger team and infrastructure and unit. And sometimes I think it can be hard. It's harder, certainly very unique challenges for the others. And it can be a chance where those individuals can have the light shined on them in a way that's a little bit outside of the clinic room, which is a little safer, I think, for many. So I just wanted that resonated with me, and it's something that I'd notice. So.
Thank you, Dr. Hall.
Any last questions? It's the Reddit theme. Ask me anything for those that know. Okay, there's one up here.
I suspect there are a lot more caregivers, maybe not for cancer, but of your own family members, it seems like. And I just wanted to say, when I've been a caregiver and a survivor, and sometimes I found it very hard to accept caregiving. And I think you sometimes have to tell yourself, it's okay. You don't have to be the one giving care all the time and giving strong. You can let people help you. And, your arm doesn't have to fall off before you decide, oh, let me go take care of that. Oh, it's not on the ground yet, so I'm okay. But always give yourself a chance to say, well, I'm not okay. I'm not the caregiver in this.
Yeah, thank you for speaking so beautifully to the fact that, yeah, we don't necessarily have such clear divisions between these two buckets all the time. And that is a unique challenge that you share. And thank you for sharing that. We have time for one more.
Thanks. It's not a question, but a statement. It's good to see you guys kind of going in this direction because personally, I think one of the big areas that we're really missing is that survivorship part, because like Fred Hutch does a great job of like dealing with cancer and like it's kind of like all hands on deck. Let's take care of this. And then, you get that, hey, you're cancer free. It's like, go live your life. You're like, how do I do that? And there's such a wide range of people here, and it's, you have a very different experience if you're older and in retirement age, but like my personal experience, like, I just turned 50, 3 years post-diagnosis. I have a young child that's in school at home, but, our American culture doesn't know what to do with all these cancer survivors that are in the middle of their life. And like, maybe you can't work anymore because, what the treatment did to you or something. You're grateful to be alive, but you have all these other issues. And it's something I don't think really gets addressed. you know, and I think our culture somewhere in there doesn't know, like, just how people don't know how to interact with when you're going through cancer or when you survive. I think as a culture, like, you know, we have very limited social safety net, things like that. So there's just so much there that it's kind of like we kind of talk around it, but we never really like address it.
Oh, yes. I mean, we saw slides about how long people are surviving because of these new treatments. And so you bring up a huge and definitely salient point to the consequences of really good medicine, right? Is what do we do as a society with all the people we've transformed, right? And how their roles have changed and how unique, and that's, I think, right, where we come in is the uniqueness of everyone's journey, because you're not all the same. So thank you. Thank you.
You guys are just great. You know, I'm a patient. My wife of 52 years is my caregiver. And it's great to have somebody to talk to when you see the pain in their face. You know, so I just want to say thank you.
And thank you.
Thank you.
Thank you.
I'm very glad to see the interconnection between the social work and the medical work. And that's a very important connection. Can you talk about the connection between the social work and the spiritual work?
Sure, yeah. That's such a great point. I don't think that's not in our slide, so great call out on that. We inhabit the same building as our spiritual health colleagues, and we bring them on board, or I mean, they're with you through this whole journey as well. Maybe next time we'll bring them along and have them present. But yeah.
Yeah, I mean, every social worker has different comfort levels. I practice an evidence-based treatment, again, Fred Hutch evidence-based treatment, called meaning-centered psychotherapy, which is very existentially and spiritually based. And while also having a lot of the typical psychotherapeutic, right, training, as we all do, but a lot of my patients see both myself and one of our spiritual health counselors. Yeah, so I really think it's unique. Thank you for bringing it up. We had one question here and then one question there. What do you think for time? Okay, yeah, do you want this?
I think my husband and I are the two oldest people here. So if you want to talk about age, yeah. And for my birthday last February, the people don't put out a whole lot of candles anymore. You just get big fat candles. So they put a 29 on my cake. And that's just fine. I'm 29, depending on what side of the cake you're standing on. If you're on the other side, then you know how old I really am. I'm not going to tell you, figure it out yourself. So this whole experience with melanoma, and I have to say melanoma is one of the scariest words that we ever use. It's not even English, but you know, it's really frightening. And I had this little oozy black something coming out of my toenail, and my doctor suggested they do a scraping and send it to PATH, send it to dermatology, which they did. And I got a phone call in the evening, somebody who did not identify herself at all. She called me up and she said, "You have a cancer." And then I had no answer for that. Then she said, "It's a melanoma." That's not a good way to spread the word. And I think there needs to be some kind of training for people. This was a doctor's office calling me, you know, and there could have been a whole lot of gentler ways of saying, even though they did connect me with Dr. Bird, who was really great. And I'm sorry he isn't here, so I can tell him so. But yeah, but after we had just given up our condominium and moved into a senior care facility. And then I had to go through the surgery. And now I don't know what I'm supposed to do with it anymore. I look at my funny looking toe when I have to, and nothing's come back, including my toenail. So I suppose the cancer is gone. But I don't know now how I'm supposed to carry on with the like being here. I was surprised when I got the invitation to come today. But you know, here I am. So there, that's it.
This just speaks to how the stressors, the things that you stay with you, that might not stay, right, with the medical professional, but that stick in with you. And so you brought up so many good themes. I wish I had time to dig into every one of them, but now you know how to get access to me. So through Dr. Hall. I think we had one more question.
I just wanted to say that I've been with Emily since the beginning of this, and I've never felt anything but welcomed by Fred Hutch. All the nurses, the nurse practitioners, her oncologist, Dr. Bird said, I remember you, going to see with Emily. So this group has done a great job with that, of making me feel like I'm part of a team. So just my comment.
So glad to hear that. Thank you.
Do you do group sessions? Because finding people that understand, that's part of being here, is other people that really get it.
Yeah, so I do group psychotherapy. So it's different than a support group. Support groups can be very helpful. Cancer Lifeline has so many great, like metastatic cancer support groups. There's just so many we can connect you with. And I do run psychotherapy groups here, which is more like therapy, but with a bunch of other people. But yes, the power of the group, 100%.
All right.
Okay.
Thanks so much, everyone.
Thank you. All right. Thanks to Alex and Tracy. I always feel like the afternoon is kind of when the program comes alive in a little different way. So many of you who've attended before probably can remember this part of the program, which is our patient and or caregiver stories. So this is usually, when I think back about years past, the part I remember most. So we have quite a story to hear. I want to thank Deb Hiss for volunteering to share her remarkable story. I think we'll all be able to learn a lot from it. It takes a lot of courage, I think, to share your story. And I just want to thank her for offering to do so. And I think I look forward to hearing it. So thank you so much for being here.
Thank you, Dr. Hall. I've got 3 hours, don't I? Oh, no, I've got 30 minutes. I have no disclosures. I don't know what that was, but my disclosure is that I am very honored to be here today to share my story with you. And Dr. Hall, thank you for inviting me. This is my 15th consecutive Melanoma Research Foundation Symposium. But I like to say that my melanoma journey started about 60 years ago, circa 1965. Ironically, that is the same year that the Hutch was established. I only learned that today because my brothers who are here with me today, who are featured here, asked me who Fred Hutchinson was, and he was a baseball player. That's all I had remembered, and I looked him up, and the Hutch was founded in large part by his brother, who was a doctor, in 1965. So this photo was taken, you see a parking lot behind us, but what is on the other side of the parking lot is the iconic Muscle Beach in sunny Santa Monica, California. which is where we grew up, we spent virtually every weekend at the beach. And we all burned and we peeled, and then we'd go back for more. So fast forward to 1975, 10 years later, I was, well, actually, no, 1975, 10 years later, I was at university. I was at UC Santa Barbara, another sunny climate. And I was sitting outside one day studying for finals with my back to the sun in a little tank top. And I fried. I mean, I had a whole new set of freckles in the shape of my tank top. So fast forward to 1985, I still lived in sunny Southern California, was still getting my dose of sun and sometimes more than I should have. And I was scratching my back and I felt something raised and I thought, that does not feel good. I looked in the mirror and I saw an irregular mole. And I knew enough from learning about melanoma. We also had a doctor as a father. So I thought, that does not look good. So I made an appointment with a dermatologist who did a shave biopsy, and it came back as melanoma. And it was measured in a Clark level. Clark level is a way of measuring the depth of melanoma. And I was diagnosed with a level 3 Clark level melanoma, which had invaded the junction between the papillary and reticular dermis. Papillary dermis is the upper layer of the dermis, and the reticular layer forms the deeper, thicker layer of dermis. So I remember calling my dad, and my dad, he was pretty cavalier. I mean, he was a doctor, so we'd be sick. He was a doctor. He didn't get alarmed, but I remember calling him and it said, "Oh, Dad, I just saw a dermatologist and I've been diagnosed with a melanoma." And there was silence on the phone. He goes, "Oh, Deb." And that's when I got scared. I thought, oh my God. So I went in for surgery and the surgeon went to town, cleared the margins. I mean, I had no idea what the result was going to be. A girlfriend came home with me that day for my outpatient surgery, and I could feel a pretty large bandage on my back. And I said, "Marguerite, check it out. Tell me what I have." And I remember she took my bandage, she went like that, and she put it back up, and she goes, "Deb, it's a gash." I'm like, okay, it's a gash, I can handle it. I have a 6-inch scar over my scapula in the back. So I was followed up with every 6 months for about 5 years back then, 1985 to about 1990, with a chest x-ray. And everything was fine, and after 5 years, those checkups sort of fell off, and I just went on my way with my life. I moved up to Seattle in the late 80s. Then I moved back down to Santa Monica for work, but moved back up here and have been back up here since 1997. My career was a very happy 42-year career in the fine jewelry industry. I'm a gemologist, and I spent time teaching at the Gemological Institute. And then the rest of my career, I traveled extensively, going into retail stores as a product and training specialist. So in 2010, later 2010, I was doing my jobs and going on flights, and there were a couple of times where I had near fainting episodes, like running for an airplane. I'd have to sit down and go, "Don't finish boarding, I'm here, come get me at the end," because I had to like gather myself. So after a couple of those incidents where I'd go up a flight of stairs and feel completely winded, I'm like, what is wrong with me? I went into my PCP, gave her my symptoms. She did an EKG that day in clinic and took my blood. My former husband and I were on our way home. We live in Magnolia, the clinic was downtown, and we got a call saying, "Doctor would like to see you again today." Like, maybe there's something wrong with my heart. My EKG maybe came out wrong. So we go back in, my doctor has this very serious look on her face, and she says, "You are profoundly anemic." Like my hematocrit was way, way low. And this was a Friday. I had all sorts of plans for that weekend. She goes, "I have you scheduled on Monday for an endoscopy, which is down to the stomach, and a colonoscopy." I'm like, well, there goes my weekend. So I go through those procedures. The endoscopy is through the esophagus to the stomach. She's thinking that I'm losing blood somehow through my elimination system. So endoscopy comes back perfectly fine. Colonoscopy, perfectly fine. She goes, "You need to get into the hospital to get a transfusion because you need more blood." I said, yeah, I'll do that after this next trip. So I went on another training trip because I was needed somewhere. I come back from that trip and I do check myself into the hospital for a transfusion. And the third of the procedures called an enteroscopy, under anesthesia through the esophagus into the intestinal tract. And so the surgeon, once I came to, goes, "Well, I found a few lesions." He didn't sound too worried. I'm like, okay, fine. He sent them off to pathology. I got a call like 2 days later from my doctor's office and said, "Dad, doctor would like to see you today, and she thinks it would be a good idea for you to bring somebody with you." I'm thinking, I'm still not putting everything together. I go, that's scary. So we go in. She comes in and says, "The lesions have been diagnosed. You have stage 4 metastatic melanoma." And obviously, our jaws dropped. It's like, what? I never connected the dots about my melanoma, my primary taken off in 1985 to now 25 years later. So she refers me to a surgeon. Well, first of all we know now are there are lesions in my intestinal tract. So now the full-on PET scan, the brain MRI, all the tests to find out where are the metastases. Thankfully, I guess, all of the PET scan that lit up was down in my intestinal tract. So the brain MRI was clear. So happy about that because it's my favorite organ. So, now what do? We go to the surgical appointment. Love this doctor. This was another Friday. And he goes, "Well, when would you like to have surgery?" And I said, "Well, as soon as possible." And he looks at his calendar. He goes, "I've got time on Monday." I'm like, put me down. I'll have another clean weekend. That's fine. So I come out of anesthesia. I go in. We don't know. The PET scan is, your intestines are like this. You don't know. I wake up and I ask my former husband, how many tumors did he find? He said 11 tumors. All in my small intestines. A total of 3 feet of my intestines were spliced out. And I thought, man, I'm missing my daughter's performance at school. Hannah, who's also here, was just 11 years old. No, she was not even 11. She was 10 years old. And she had a cute part in a performance. And I was lying in bed in a hospital going, wow, 11 tumors were just taken out of me. Okay, darn, I missed her performance. But wow, I have dodged a bullet. So I recover. I'm in the hospital a couple days, 3 days maybe. I come out. 6 weeks later, it's life as usual. I'm back exercising. I'm back training and traveling and feeling, again, so incredibly lucky that the metastases were just where they were. So that was June of 2010. In September of 2010, I started feeling funky again, like weak and winded. So I went into the hospital, I went into my doctor, and it was revealed that I was again very low in my hematocrit, profoundly anemic again. So I was checked into the hospital to get a transfusion. And while I was there getting the transfusion, they conducted a CT scan. The CT scan revealed a new tumor in my mesentery. So the mesentery is, let me see what I call that. The mesentery is, it attaches the intestines to the posterior abdominal wall. This time, the tumor was deemed inoperable. This is real scary. So I was due literally the next day to fly down to Santa Monica because my sibs and our kids would get together every year down at the scene of the crime in Santa Monica. And I'm lying in the hospital going, what is going on? Now I will tell you, do you know what a hospitalist is? It's a doctor who's not your doctor but makes the rounds. This hospitalist is the one who informed me that I had this inoperable tumor, not my oncologist. And this was before I was referred here. And when he said, oh, by the way, the CT scan reveals an inoperable tumor, I said, well, okay, what does that mean? He said, you will probably be put on palliative care. I'm bawling. Right? This is a doctor. You trust a doctor. I realized later he had no right. It was not my oncologist who said that. It was somebody who did not know my story, my case. So moving on. I did take that trip with my daughter. We went down to Santa Monica. We went to Magic Mountain. And I swear I lived that weekend like it might have been my last weekend with my family. We went on those scary rides and I thought, bring them on. We went on that freaking scary ride X2 where you go up backwards and then you just come down like this when I'm like, hey, it can't be any worse. Just bring on the scary rides. Get my mind off of this. So I come back home. My oncologist at another clinic referred me to, at the time, Seattle Cancer Care Alliance, to a melanoma specialist. She was no nonsense, Dr. Kim Margolin. I don't know if any of you know her. She has moved on. I owe her a lot. No nonsense. Bedside manner, not really, but she was a cool dresser and she got right down to it. Now, keep in mind, this was October 2010. She says to me, Deb, you're in pretty good shape. There aren't a lot of options for you right now for treatment. There are some things that are in trials right now that are showing great promise, but none of them is FDA approved yet. So because you're in pretty good shape, we're going to put you on IL-2, interleukin 2. She goes, there's some pretty harsh side effects. Like what, I ask? Fuzzy brain, no problem. It'll come back. You're going to feel like you were hit by a Mack truck. Bring it on. I have an 11-year-old child that I want to see grow up. Fluid retention. What's a little fluid? And a few other things she mentioned. Okay, I check in. Oh, so the other thing is, we knew that I was going to do this and I had to spend time up at the ICU at UW, 8 Northeast at the time. So I'm already, like I'm geared up. You know how it goes. Mentally, let's go. Let's start yesterday. I had to wait for about 3 weeks for a bed to open. Every day, it was painful. We'd check in, it's like, there's no bed available. Finally, in November, I started course 1, October, course 1. So there are 2 cycles of each course, and I had to do 4 total stays in the hospital. IL-2 involved getting a dose every 8 hours for 14 total doses, if you can handle them. And if you miss 3 doses in a row, you're out. I come in, I'm ready to go, I'm bring it on. Get a dose, I immediately get the rigors, the shakes. I'm like, what is happening? But the care team were so amazing. The nurses were always there with a shot of something. Thank God. So 8 hours later, comes time for my second dose. They have to take my blood pressure because your blood pressure has to be at a certain level, and I already have low blood pressure. Not high enough. Skip the dose. They're pumping me now full of pressors, vasopressants, to, what are they called? Vasopressors, yeah, to constrict my vessels so that my blood pressure will come out. Okay, so missed the second dose, third option, the third dose comes around, blood pressure not high enough. Blood pressure not high enough. One more and I'm out, right? And I'm thinking, come on. I'm thinking, come on, let me do some calisthenics. Let me go do some jumping jacks. Lo and behold, by the fourth dose, my blood pressure was high enough. So I was able to take that. I'll cut to the chase on that one. I ended up taking 10 out of 14 doses of that first round. However, I rolled out of the hospital, and I literally mean I could have rolled with 49 pounds of fluid retention. Yeah. So rinse and repeat. I had to do that 3 more times. And I finished my last stay getting only 2 out of 14 doses in January of 2011. I spent New Year's Eve, 2010 to 2011 in the hospital, but I was happy to be there. You know how it goes. So I finished right before my 55th birthday, and I was given Lasix, right, or whatever, diuretics. And every day I was stepping on the scale at home, and I was like down like 7 pounds, down 8 pounds, down, I mean, every day until I was back to sort of who I recognized. One brother came up, well, actually, with the first round, my younger brother brought my daughter, who now again was 11 years old, to the hospital through this ordeal. And Paul said to Hannah, look in the mirror and get your ew face out right now, because when you walk in and see your mom, she's going to look a lot different. And then my other brother came up right after the treatments, and I remember him coming through the front door, and I'm lying in my easy chair, and I said, don't be alarmed, because I really was the Michelin girl. Anyway, so we get past the IL-2. I'm happy I'm done. For a while, I showed a pretty good partial response because there wasn't very good response rates with IL-2. So I was scanned. So that was January. I was probably scanned in April. And then I started having some abdominal cramping in 2011 of September. So we did a PET scan, and it showed a tumor in my upper abdomen. Whether or not it was the same tumor, I can't remember, but there was a melanoma tumor. Okay, Dr. Hall talked about when he graduated from medical school. November 2011 is a significant date for him. It's a significant date for me, because guess what became FDA approved? Ipilimumab. The title of my talk is going to be Timing is Everything. Ipi was FDA approved. I sailed in for my Ipi infusions, 4 outpatient every, I don't know, 4 doses, 2 weeks apart, 3 weeks apart. I had no side effects. I asked Dr. Margolin, I was a little suspicious because I think about IL-2. I said, is there any correlation between side effects and efficacy of this drug? And she goes, honestly, it's pretty new. We don't really know. We're going to learn from you and some other patients. So that was November. And I was scanned for every 3 to 6 months as follow-ups. I went into remission. And I thought I had kicked its ass. So I lived in remission for 3.5 years. 3.5 years. Then I came out of remission, and I was bummed. I'm like, I thought I had beaten this thing. So in September of 2015, a PET scan showed 2 suspicious mediastinal lymph nodes. That's the area between in the chest between the lungs that contain the heart, blood vessels, esophagus, and lymph nodes. So down here, mediastinal nodes. My now doctor, Dr. Bhatia, put me on a RADVAX protocol, sort of a trial combining Ipi with some radiation. So I had 2 nodes. So they targeted via radiation 1 node and left the other one unradiated. And then I went on to some Ipi. Well, that didn't seem to stop the progression of the tumors, because, so that was November of 15. In March of 16, a PET scan revealed 2 new hypermetabolic periaortic nodes, so again, alongside my aorta. So then my doctor put me on pembrolizumab, And that was right when we knew that Jimmy Carter had gone into remission from his brain mets because of Pembro. So that's Keytruda. So I was doing dosing every 3 weeks. And then that was April of 16. In January of 17, I was transitioned to every other month Pembro. So the good news, bad news about some of these immunotherapies is you don't really know the end game. So I didn't really know how long I was going to be on the Pembro. But again, I didn't have any side effects, so I didn't care. But Dr. Bhatia turned me over to every 2 months in January of 17. In February of 18, I received my last dose of Pembro. So that was almost 2 years that I was on Pembro. And then I went into remission again. So I was in remission until March of 22. So that's a good few years there. That's like 4 years again. So in March of 22, surveillance imaging showed some nodules. One was in my clavicle and one was down below my trachea. So they were able to do a needle biopsy on the subclavicular node near my clavicle, and it did test positive for melanoma. I wasn't surprised. Hey, I'm glad it wasn't something new, honestly. It's like, oh, phew, it's just melanoma. Okay, so in August of 22, I remember having a Zoom call with Dr. Bhatia because we were still in the throes of COVID. So we did a Zoom call, and he said, there is a new combination of immunotherapies that I would like to put you on. And he actually dared to say, we won't hold him to it. So if Dr. Bhatia is your doctor, don't say, now you told Deb that. But he said, wouldn't it be great to eradicate melanoma once and for all? And I said, well, it sure would be. So I was put on Opdualag. That is nivolumab and relatlimab. Anybody here been on Opdivo? Okay, Opdivo. So I started with, let's see, it was monthly Opdualag, going outpatient, of course. The nurses in the infusion bays, aren't they the best? I just loved every one of them. I wanted to take them all home. Anyway, I started in August for 12 months, so monthly for a year. And then Dr. Bhatia put me on reduced frequency every 3 months for the next year. So my last dose of Pembro was July of last year. Now I'm going to tell you something before I end here, because I wasn't going to, but after listening to Dr. Hall speak, I am going to share something with you. So my last dose was July of 2024. In September, I developed some very weird skin rashes. I was in Italy with a girlfriend. All of a sudden, I was just scratching, itchy. I went to my original dermatologist, who's not at the Hutch. I ended up over 2 derms at this other clinic getting 3 different punch biopsies and 3 different diagnoses. First, it was eczema. No, it's not that. Oh, it's scabies. You picked up scabies in Italy. No, not that. And then it's bullous pemphigoid. No, my blood didn't have the antibodies that should have been present for bullous pemphigoid. Then I thought, dummy, why don't you go see a derm over at the Hutch? Because there's this there's this collaborative work here with cancer and dermatology. So my dermatologist has now determined that this is probably a delayed response or a response to the immunotherapies. So I've been put on a biologic. And do I complain about the itchiness? It's not so bad anymore because of the biologic. But when I was in the throes of it, I'd be scratching and I go, at least I'm alive to complain about this. So anyway, I want to finish by saying that thanks to immunotherapy, thanks to the Hutch, I am seeing my daughter grow up. She's 25 years old now. And my last scans, February 14th, I have no evidence of disease. I'm in remission. Thank you. Obviously, I'll take any questions anybody has. Done, bro. Oh, yes. I'm sure it is. my brother. Don't get personal.
Some of your secrets.
Yeah, good.
Here's Johnny. So I've been meaning to ask you this since that picture was taken of us, is which of us brothers is your favorite and why is it me? So I don't have any questions for you because I know everything, but I just want to tell everybody here what a trooper you have been through this whole thing. You've just handled this with aplomb. I mean, really, you've never gotten down in the dumps. You've always just taken it on like it's a task that needs to be done, and you're here to talk about it. I also want to say it's incredible the work that's being done, and that you are so fortunate. We're all so fortunate that the timing was good for you, that the immunological therapies worked, that you haven't come down with any rheumatoid arthritis or adrenal gland failure or whatever else can go wrong that you've seen go wrong. I mean, it just gets me, the amount of good work that's being done. And of course, the work's not done yet. But I just wanted to say thanks for your story. Thanks for being my sister. Thanks to my brother and my niece. And thanks to everybody here for all the incredible work that's being done.
Thank you. There is a quiz later, so if you have any questions.
I got a similar story. I was raised on the beach in Edmonds. Put the baby oil on, get fried, put the baby oil on again. And an avid skier. 2018, I had a little melanoma right here. Had it surgically removed and everything was good. And September of 22, I had a melanoma where the sun doesn't shine. And had surgery. Passed around a couple doctors. Got to see Dr. Hall, and two things I told him. I got to get to my 50th anniversary, and I want to ski again. And he says, well, you're lucky that you're here now because I was on the IPI and the vol lab. And he says, I don't know if you'll ever be able to ski again because you're so compromised in your lungs and liver. 6 months later, I sent him a video from Big Sky, Montana at 10,800 feet of me skiing down the mountain. We went to Sicily, where her grandparents are from, had her 50th anniversary. I just got back from Montana skiing 34 days.
With sunscreen on.
Yeah. And I was diagnosed with stage 4. And, it's all about, positive attitude, surrounding yourself with positive people, your family, your faith, the science and the good people here. But, it's a journey and can never give up. And thanks for telling your story.
Thanks for sharing, Lily.
We've been coming here for 10 to 15 years. My wife is the survivor. Today we met two new couples who are here for the first time. And they should know that we have heard this woman speak previously when she was one of 3 people. So she was sharing the half hour with 2 other people. Today was the complete story. And what you should understand is if you never give up and keep on trying, sometimes you will be successful.
Right.
And this is the next issue of her story. Maybe she'll be back in 2 or 3 years. Maybe she will be clear in 2, 3 years. We don't know, but there is always hope, and it's gaining now that new treatments and vaccines are coming online.
Thanks for remembering that. I spoke in 2012 and I didn't have notes because my journey wasn't as long as it is now. Thank you all. Thank you.
All right. Wow, that was wonderful. Thank you, Deb. When I started working with Dr. Burt on this, he always said, you got to end with the patient stories. And I defied that this year. And now I'm remembering why we tend to end with the patient stories, because it's so powerful. But if there is one person in melanoma who I think can maybe follow that, it is Dr. Julia Lai-Kwon, who is speaking to us all the way from Australia today. And the reason she's speaking at the end is because it's 6:50 in the morning where she is. And, you know, oncology, one of the best parts about being an oncologist is getting to meet people at meetings kind of serendipitously. And I met Dr. Lai-Kwon at a poster that she was presenting in Chicago. It was probably 2018. And it's clear that we had a lot in common in terms of what interested us. And since that time, she's just become a rock star. So it's really exciting to introduce her to tell you all about what she's been doing in Australia and worldwide, and have her conclude our symposium this year. So she is a medical oncologist and health services researcher at the Peter MacCallum Cancer Centre in Australia. She, after becoming an oncologist, then went back and either got or is almost done with her PhD. So she's an amazing person in that regard. And her work is really intimately connected to this symposium. She's focused on quality of life, survivorship, symptom monitoring for people getting immunotherapy, and improving outcomes for patients with skin cancers. She's a part of many international leadership bodies looking at quality of life measurement, symptom management, and immunotherapy toxicities. And it's really a pleasure to introduce her virtually. Good morning, Dr. Lai-Kwon. Thank you for speaking with us at our symposium today.
Thank you very much, Evan, for that very kind introduction. Yes, hi everyone. I'm coming to you all the way from Melbourne, Australia, and yes, it is 6:50 a.m. And luckily, I did manage to wake up in time for today's presentation because we had a daylight saving change, and I had a last-minute panic that maybe I was waking up 1 hour early or 1 hour late. So luckily, we're here at the right time. So thank you very much for having me. So yes, as Evan said, my name is Dr. Julia Lai-Kwon. I'm a consultant medical oncologist from Peter MacCallum Cancer Centre, where I focus mainly on skin and melanoma. But my research interests are very much focused on the area of survivorship and symptom monitoring, as Evan has said. And so today I'm going to be talking to you about how we can possibly improve the care of people living with advanced and metastatic melanoma. And I just briefly caught the end of that fantastic patient story that we just heard. And I think that that spoke volumes about, you know, the challenges that people face over the course of their diagnosis, particularly with stage 4 disease. And so, yes, we'll be talking about how we can potentially improve the care of this population as a whole. So hopefully my slides will work. So this is a brief outline of my presentation today. So I'll be talking about this population, I guess this emerging population of cancer survivors.
I think we're
not
seeing your slides.
Oh, hang on. Yeah.
I don't want to let you get too far ahead.
Is that better?
Yes, that's right.
Yes. Okay, excellent. All right. So yes, this is the outline of today's presentation. So we'll be talking about this emerging population of cancer survivors, people living with advanced and metastatic melanoma, and who this population exactly includes. We'll be talking about what sort of issues these people might face in terms of physical, psychological, and social issues. And then we'll talk about how we might go about improving their care. So the key points from today's presentation are really that, you know, people living with advanced and metastatic melanoma are a growing group of cancer survivors, which is a fantastic thing. But we also know that these people can face a unique range of physical, psychological, and social needs. But there's much that we can do to improve their care. And I think we need to work towards delivering more personalised care for this group of cancer survivors. And this would involve, you know, making sure that we're discussing prognosis on a regular basis, as this can change over people's disease trajectory. Screening people regularly for their concerns and unmet needs and making sure that they're referred to appropriate services. creating new models of care that really blend both the best of both worlds, so the best of survivorship care, but also palliative care for people who are not doing so well. And we also need to improve communication between healthcare professionals, as people will often move between cancer, between acute and community settings over the course of their disease. So firstly, to this population of people living with advanced and metastatic cancer, metastatic melanoma, who does that really include? So this little illustration just shows the populations that I'm referring to. So we're here to talk about people with, stage 3 melanoma that is not resectable, so where surgery is not possible, as well as people with stage 4 melanoma, where melanoma has spread to other parts of their body, or metastatic melanoma, as it's otherwise known. And this group of people, as you will know, is typically treated with drug treatment, so with immunotherapies as well as targeted therapies or even clinical trials. And as a result of that, people will either respond to those treatments, or they sadly will not respond to those treatments. But this entire group of people are still living with advanced or metastatic melanoma. So that's the group of people that we'll be talking about today. So it spans quite a large range of people. Obviously, people who maybe are not responding to treatment and may have a shorter term prognosis, but also people who are going to do very well as a result, particularly of immunotherapy, and may even have very long-term disease control or even potentially cure. So it's a very broad population. So historically, we all know that, the prognosis of melanoma, if you go back about a decade, was not very good, and that people's prognosis was often very short, often measured in months. But thanks to a lot of the novel sort of therapies that many of you have received, such as immunotherapies and targeted therapies, people are living, thankfully, a lot longer. And in some cases, people may even respond to those treatments long term, and may even be potentially cured, as I've just mentioned. But I think that this, potential to, cure, even in the context of stage 4 disease, is something that is relatively new, and something that melanoma has really led the way. And so we're still learning a lot about how we can best manage this phase of people's lives, which we refer to as the survivorship phase. And previously, survivorship was really only described in the context of people with early stage cancers that were treated with, curative intent. And the survivorship phase was often thought of as what happens after people have finished their acute treatment. But now we're talking more about people with, unresectable stage 3 disease, as I said, and stage 4 disease, who are living with their melanoma for potentially long periods of time. So what sort of issues do these people sort of face? And this little diagram shows, I guess, the breadth of issues that people might experience whilst living with metastatic or living with advanced or metastatic melanoma. So obviously there's the side effects of treatment, and many of you will have experienced some of these. So there's, the acute as well as the chronic toxicities associated with immunotherapy. And over time, it's the chronic toxicities that become particularly burdensome, particularly fatigue, rashes, pruritus, arthralgias, etc. But even long-term targeted therapy can also have long-term toxicities as well. Psychologically, people often experience a number of issues, depression, anxiety, managing the uncertainty of their prognosis, fear of their cancer coming back or progressing, as well as anxiety around scans because of that. Financially, and obviously this is a bigger issue, particularly in the US compared to Australia, but there are many sort of financial issues associated with living with advanced or metastatic melanoma. There's medications to pay for, difficulties accessing insurance because of the diagnosis, difficulties maintaining work if you're well enough, or returning to work if you're doing very well, and also the challenge of potentially self-funding therapies along the way. People often have a lot of informational and health system navigation needs, so they don't have a lot of information about their overall prognosis, which makes it difficult for them to make life decisions. They may also be on a clinical trial long term if they're doing well, and this, is often quite burdensome with lots of visits and scans. And if you're on the trial for many years, then you're often exposed to needing to, come in for appointments, needing regular scans on a very regular basis. Socially, people also experience a number of challenges. It can be challenging discussing, where you're at with family, friends, and work because it often changes a lot. And, particularly for people who are doing well on immunotherapies and targeted therapies, there may even be a perceived sort of lack of empathy from people around you because you're doing extremely well, you don't look unwell, and you don't really fit that traditional, what we refer to as the sick role. And for carers, they also experience a number of issues unique to them. They may be providing psychological support to patients over a long period of time, and they also need, information about prognosis, etc., for them to be able to make decisions. So many of these issues will probably ring bells for many of you in the room today. Yeah. So back in, I think it was now 2018, we conducted one of the first sort of surveys asking people living with advanced or metastatic melanoma at our centre about the physical, psychological and social sort of impacts of their diagnosis and treatment. And this, later was followed by a series of other sort of groups looking at this in both the UK as well as the United States. But this slide here shows some of the physical sort of side effects that people reported to us, both on immune checkpoint inhibitors as well as on BRAF and MEK targeted therapy. So we've got immune checkpoint inhibitors on the left and the targeted therapy on the right. And you can see the questions that we asked people about their sort of physical side effects. And you can see on the coloured bars, green showing people who are experiencing those side effects, and the brown showing people who didn't report those side effects at all. But, well over 50% of people were reporting, a range of issues on both immunotherapy and targeted therapy. So tiredness, itching, dry skin, trouble sleeping, feeling weak, and joint aches and muscle aches and pains. And interestingly, these side effects were actually very similar between immunotherapy and targeted therapy, even though we know they have slightly different, they have quite different side effect profiles. But over time, I think particularly in people doing well, these toxicities seem to converge around these particular symptoms. We also asked people about, how they were going psychologically. And I haven't shown it here, but we also saw quite high rates of depression and anxiety, again, above, or self-reported depression and anxiety, again, above, I think it was 50%. But this slide specifically looks at people's concerns about their cancer coming back or getting worse. So that's referred to as fear of cancer recurrence or progression. And again, we saw significant levels of concern around this issue in both people receiving immune checkpoint inhibitors and targeted therapy. And interestingly, this was a population of people who had done very well on their treatment, and some of them had been on treatment for many years. And as oncologists, we know that this group of people are likely to do very well. But clearly those conversations hadn't been had clearly with people, or they hadn't absorbed that information. And so they were still very, very worried with every scan about their cancer coming back, even though the chance of that was very low. We also asked people about, how their lives, socially had changed in terms of their roles and relationships. And again, people reported a range of difficulties in their day-to-day activities, doing domestic chores, recreational activities, financial difficulties, and this was a population obviously in Australia where we have essentially universal healthcare, but people still had financial difficulties paying for medications, transport, accommodation, etc., associated with their treatment. And people also had difficulties concerning their work. And this is obviously particularly important for this population, as many of them were either working or trying to get back into work, given that they were doing well from their cancer. So obviously there are a number of areas in which we can try and improve care for people living with advanced or metastatic melanoma. But while we're here focusing on melanoma today, this issue is broader than just people with melanoma. We know that there is a growing population of people living with advanced or metastatic lung cancer, renal cell cancers, bladder cancers, particularly cancers that are treatable with, novel therapies like immunotherapy, where people will have a chance of, long-term disease control even with stage 4 disease. And this whole field is now referred to as what's called metastatic survivorship. And there's been a number of different articles published in the literature drawing attention to the issue of metastatic survivorship in recent times. And this sort of culminated in us putting together an opinion piece for the Journal of Clinical Oncology, which is a major oncology journal based in the States, about, the challenges that people face living with metastatic survivorship. So really bringing that literature together and trying to work out a way forward. And as part of that paper, we kind of identified some priorities that we as healthcare professionals, but also, you as patient advocates can help to advocate for in terms of people's care, research priorities, as well as priorities for healthcare policy. And that's kind of what's shown on this diagram. And I won't go into a lot of detail about it, but, you can read a couple of things particularly pertaining to care that I think, might ring some bells for people as being particularly important. Discussing prognosis on a regular basis, making sure that we address, financial toxicity, ensuring people have the right sort of information to make decisions about their work and finances, etc. And as a result of that, these have now been aligned into some international standards that were published last year, jointly by the American Society of Clinical Oncology, as well as an international group that focuses on supportive care, which is called MASK. And they've put together these 7 different standards, which really are sort of practice recommendations for ideal metastatic survivorship care. And this will be the focus of an educational session at this year's American Society of Clinical Oncology annual meeting. But what I'll do now is I'll just sort of focus on some of the, probably the top 5 sort of priorities from those recommendations. So I guess firstly, the thing that really popped out to me was the importance of discussing prognosis regularly with people living with advanced or metastatic cancer, and making sure that this information is as tailored and realistic as possible, and that these discussions are held on a regular basis. As we've heard today, people's disease trajectory can fluctuate over time. There'll be periods where they're doing very well on treatment, periods where they're not doing so well. And we need to make sure that people understand where they sit on that disease trajectory at any one point in time, because really that's the information that you need to be able to make important decisions, what you want to do with your life, what you want to do with work, how you want to manage your finances, etc. But we need to acknowledge, obviously, that there's a lot of uncertainty when we talk about prognosis, and we need to become increasingly comfortable with sitting with that degree of uncertainty. And as we have these discussions, we need to make sure that that information is communicated, not just to within, the oncology team specifically, but to the rest of the healthcare team, people's primary healthcare professionals, etc., so that everyone's on board with where people are at. Because this is obviously quite important when you think about how we manage people's other medical conditions like high blood pressure, high cholesterol, and that to make sure that we're making the right decisions about treatment of those conditions as well in light of people's prognosis. The second priority that we should focus on is really screening people for their concerns and needs on a regular basis. And this really is not done very well. I mean, it's described, throughout the literature that it's important that we understand what people's physical, psychological, and social needs are holistically at any one point in time. But in reality, this is not done very well. But this sort of diagram shows how we might go about doing that. So, from the point of diagnosis of advanced or metastatic melanoma, we really should be routinely screening for physical, psychological, and social unmet needs. And there's a range of different surveys that we can use to do that. And then once we identify people's level of need, whether that be minimal, moderate, or high, we should then offer people sort of risk stratified personalized care where possible. So, often people will have minimal needs and they can sort of self-manage with a little bit of information provided. Some people might have moderate levels of need and might need to be referred to some supportive care services. But people with high levels of need really need to be managed in specialist centres, whether that be, high levels of depression, anxiety, fear of cancer recurrence. And they should be referred to specialised services, ideally within, a tertiary cancer centre. And then obviously people's needs can change throughout the course of their diagnosis. And so we need to be rescreening people throughout care. And as Evan mentioned, I do have an interest in symptom monitoring, and electronic patient-reported outcome systems can help to facilitate all of this and integrate this sort of information into the electronic medical record so that it's there for healthcare professionals as they need it. So we tried to implement an example of this type of screening in a project that was conducted at my centre, as well as the Alfred, which is another melanoma centre in Melbourne and funded by the Victorian government. And this program focused on screening people and managing fear of cancer recurrence or progression in people with unresectable stage 3 and stage 4 melanoma. And we called this program Fearless. So basically what we did is once people were newly diagnosed, we routinely screened them for the issue of fear of cancer recurrence or progression using 2 different surveys. And then we classified people using established cutoffs from those questionnaires into having either mild, subthreshold, or clinical levels of fear of cancer recurrence or progression. And then based on that, we provided them with, personalised care. So if you had very little in the way of issues, it was really standard of care, which is no management. People with sub-threshold levels were provided with a customised self-management resource, so provided with some psychoeducation as well as a self-management booklet. And then for people who had clinical levels of fear of cancer recurrence, they were referred to a evidence-based intervention, which is called Conquer Fear, and had 5 sessions of individualised therapy. And then people were rescreened as well over the course of their cancer. And this was a feasibility and acceptability study. So we did find that overall this model of care was feasible and acceptable to deliver at our centre and at the Alfred. Interestingly, we found that, the prevalence of these issues, fear of cancer recurrence and progression, was quite high in this group. So it was around 64%, which is very similar to what we found in that survey that I showed you right at the beginning. And pretty much all of those people had never had their issues addressed. And I think this highlights the importance of screening for these kinds of issues on a regular basis. So we are hoping to conduct further studies of this intervention, looking specifically at its efficacy and whether it's cost effective to deliver, because obviously it is quite resource intense, but I think, with integration to electronic systems, you can do a lot of this screening in an automated fashion. The third priority is really, referring people to appropriate supportive care services once you've identified those needs. And where possible, we want those services obviously to be specific to people living with advanced or metastatic melanoma, although that's not always possible. But, we do have quite a lot of interventions that we can deliver for common sort of survivorship issues that people have, as shown in this diagram. But I think we also need to think about identifying, where there is no clear intervention for a particular issue that people might be experiencing. We need to also start developing supportive care trials to try and create, a management strategy for those particular issues. So one specific service that we've kind of looked at developing at our centre, and this is actually in people living with advanced or metastatic lung cancer as opposed to melanoma, but is equally applicable to people living with melanoma, is this intervention known as Cancer and Living Meaningfully, or CALM. And we've done an adaptation of this CALM program for people living with advanced or metastatic lung cancer who've received immunotherapies or targeted therapies. And this was a collaboration that we ran in conjunction with Princess Margaret Cancer Centre in Canada. And basically, again, this was to understand, the feasibility and acceptability of delivering this CALM program in this patient group. And basically, CALM involved 3 to 6 sessions delivered via telehealth or face-to-face with either a lung nurse or a psychologist, focusing on goal setting, and how people might live meaningfully with the uncertainty of their prognosis whilst living with stage 4 cancer. And overall, again, we found that this program was feasible and acceptable to deliver. And we also found some preliminary evidence that it actually reduced people's depressive symptoms, improved their quality of life, and reduced their anxiety around death for those who are not doing so well. But this is this is unpublished data, and we're hoping to publish that later this year. The fourth priority is really around creating new models of care to really look after people living with advanced or metastatic melanoma. And as we talked about, people's needs and their prognosis can obviously change over the course of their disease trajectory. But care is often typically organised as being either for survivorship care, so people treated with a curative intent, early stage cancers, and people living with metastatic melanomas don't fit into that category. But then alongside survivorship care, you also have palliative care, which is obviously focused on people who are living with a terminal illness, and particularly focused on those towards the end of life. And people with, who are living with metastatic melanoma often fit in between those two groups. And so we really need to draw upon, the strengths of both of those different programs to try and create a new model of care to manage the issues faced by this emerging survivorship group. And that's what's kind of shown in these diagrams. Both survivorship care and palliative care bring different strengths to the table in terms of what they can manage and what their areas of expertise are. And really, we need to blend those two together in order to create the best model of care to really manage people's needs living with advanced and metastatic cancers. And then finally, as I said before, I think we also need to look at improving communication and coordination of care between healthcare settings. So we know that, people living with advanced or metastatic melanoma will often move between acute settings like the hospital, as well as community providers like primary care providers. And we need to make sure that these transitions are as smooth as possible and everyone understands what's going on at any one point in time. And this can often be facilitated by some sort of document, which is either termed, a survivorship care plan or an advanced care plan. But neither of these terms are really appropriate, I guess, for people who are living long-term with, advanced or metastatic cancer. But, I think overall, these plans need to contain information about, a person's diagnosis, what their current sort of prognosis is, how long they're expected to live for, what sort of physical, psychological, and social issues they might be experiencing, and how we might want to go about managing comorbidities, so that really everyone, across a person's care is on the same, on the same page in terms of where that person's at any one time. And we tried to implement this type of plan as part of a study that we conducted at Melanoma Institute Australia in conjunction with one of our patient organisations, Melanoma Patients Australia. And this study was called MELCare. And what we were testing here was really a nurse-led model of survivorship care for people living with advanced or metastatic melanoma who'd received immunotherapies and targeted therapies. And this model of care was delivered via telehealth. And again, we wanted to understand the feasibility and acceptability of this model of care. And how MELCare worked is kind of shown in this flow chart. So what we did at the beginning was we screened people for their concerns and unmet needs using this survey called the Distress Thermometer and Problem List. We then did an initial telehealth conversation with them to understand those issues and to implement a management plan. And then based on that consultation, the nurse produced a survivorship care plan, which was then shared with the participant, their primary care provider, as well as their medical oncologist, so that everyone understood what those issues were. 3 months down the track, we then did another consultation with people. We re-administered the same surveys to see if those needs had changed. And then we did a follow-up consultation with them. And then people completed some surveys as part of the study. And overall, again, we found that this type of care model was feasible and acceptable to deliver. And we also showed that it helped to reduce people's levels of distress, although that was a preliminary finding of this study. But obviously, providing this type of survivorship care, which was delivered via telehealth, so it's really easy, people didn't need to come into the centre, is applicable to people who are receiving other types of therapies as well. So this is not just specific to people with melanoma, but we could apply this to people living with lung cancer, renal cell cancer, bladder cancers, etc., as we've talked about before. So that just brings me back to the key points from today's presentation. So we've talked about how people living with advanced or metastatic melanoma is pleasingly a growing group of cancer survivors. But we know that this group has a range of unique physical and psychological and social needs that need to be better addressed. And so we've outlined a couple of ways in which we can try and improve their care by really personalising their care as much as possible. So making sure that we're discussing prognosis regularly, that we're screening people for their concerns and unmet needs throughout their disease trajectory and referring them to appropriate services, looking at how we might rearrange care to better look after this emerging patient group, and improving communication between healthcare professionals. So there's many people to thank who've obviously been involved in this research, and they're all shown on this slide. We've had a lot of collaboration across multiple centres as well to conduct a lot of this research. And finally, thank you very much to the study participants for their time and efforts as well.
Thank you very much. That was a wonderful talk. For those who don't know, Australia has the highest incidence of melanoma in the world. So you may have noticed seems like there's a lot of institutes of melanoma in Australia. It's because there's a lot of melanoma in Australia, and our colleagues from Australia have been really at the front leading edge of helping us change care for our patients. Dr. Lai-Kwon, thank you for getting up early to join us. Does anyone have a question for Dr. Lai-Kwon? One thing that I find particularly impressive is that designing these interventions and systems, I will just tell you, having been on the research side, that is the hardest type of research to do. You identify a gap or a need, and you try to actually address it. It's a lot easier to just say what's not working than to actually test and try to find something that works. So at least from a research perspective, I find her work very inspiring because she's actually going that next step and saying, here's the issue. We have a question from the back.
Yeah, thank you.
Thank you. Doctor, if you know, why is the incident rate so high in Australia?
So I think there's multiple factors why. I mean, obviously we've got a predominantly Caucasian population, mainly drawn from people who, were living in the UK, so a very sort of fair skin type, and that coupled with a very outdoor lifestyle, high rates of UV exposure has probably led to the high incidence of melanoma in Australia. So yes, I think hopefully, though, I think there was also some cultural aspects, people obviously spending a lot of time in the sun, at the beach, the typical sort of Australian lifestyle. But I think that is gradually changing over time. We've had a lot of public health efforts in recent years to try and make people aware of, the importance of checking UV as part of like checking the weather forecast almost, and really, making sure that they're doing, what we term the 5 things, so flip, flop, slap, slide, and seek, which refer to the 5 sort of behaviors that you can do to minimize your exposure to UV. So hopefully we will see a decrease in the rates of melanoma over time.
I'd like to make a comment, and I have a really loud voice, but first of all, I really enjoyed the fact that you talked about discussing the prognosis all along. I thought that was excellent. And the second thing is the financial considerations. I work and I live alone, and no one ever talks about that. And it's been a battle when I'm off to try and get my bills paid and go through the steps I had to do to get some help. So those are 2 excellent points. I would love to see a handbook or like a pamphlet of what you suggested given to caregivers. Thank you very much.
Yeah, no, thank you. When you say suggested to caregivers, was that in relation to financial toxicity or more as a broad sort of broad recommendations for caregivers?
For caregivers, yes. I finally managed, but it was hell. Hours on the phone trying to find out how I could solve some of my problems. I'm back at work now. It was very hard.
Well, good to hear you're back at work, but I think, yeah, I mean, financial toxicity is a major issue for people living with cancer, and it's no greater than in the US, obviously. But even in Australia, as I said in the presentation, where we have a universal healthcare system, we do find that people still experience, difficulties financially. People are still required to pay for like tablet-based medication in Australia, whereas intravenous medications that are delivered in hospital are supplied by the government for free. But they also need to pay for, any supportive care medications that to treat any side effects that arise from their treatment. People who travel a long way to hospital have to pay for transport, accommodation, meals. Some of that is reimbursed by the government, but they're often left out of pocket for long periods of time. So, those are sorts of the financial issues that people face in Australia, but obviously they're much more profound. Just accessing treatment in the US is challenging because of financial toxicity. And then, for caregivers, there are specific resources that have been developed for caregivers of people with cancer in general by, various non-government groups in Australia, like Cancer Council, etc. But there isn't anything that's specific for people caring for people living with like advanced or metastatic melanoma or advanced or metastatic cancer of any kind. And I think that would be very helpful.
Great. We will, that's a very thoughtful answer. Thank you. We will maybe end off with one more question from the chat. And I guess this is almost a philosophical question for Dr. Lai-Kwon. How do you handle a patient who's a long-term metastatic survivor? What words do you use? And the question is using words like remission or using NED. Do you ever use the word cure? If so, when? How do you approach this scenario in your clinic?
Yeah, no, this is a great question, actually. I think it's very context dependent and very specific to that individual patient. But, in the best case scenario, if I've got a patient living who's got stage 4 melanoma, who's received, first line immunotherapy and responded extremely well to that treatment, very early, with a very early response on their PET scan, I think we are pretty confident at that point that this is a person who may potentially get long-term disease control. And that's usually the term that we use. And when we talk about control, we talk about, on the scans, the melanoma shrinking or even completely disappearing, and that could be sustained. And then as time goes on, and we become more confident that sort of response is likely to be sustained, then I think, towards the 5-year mark, we start to talk to people about this being potentially a cure if they've remained in that response. And we actually now discharge all our patients at 5 years if they still have had a complete metabolic response on their PET scan and there's no, disease visible. So we have basically said to their general practitioners or their primary healthcare providers that this patient is essentially cured as far as we're concerned. And that their melanoma is extremely unlikely to come back again, and that that they don't require any more scan surveillance. So yeah, we do use the word cure, but I think we use it more towards the 5-year mark once we become very certain that person's response to treatment is likely to be sustained. But up until that point, we talk to people about long-term control of their cancer. Yeah. Remission is kind of an interesting word. I don't tend to use it. It probably is often used more in like a hematological context in the sense that it's quiet for now, but it probably will come back later, whereas that's not always the case with people with immunotherapy. If you've had a good response, maybe it won't come back at all.
Great. Well, thank you so much for getting up very early on a Sunday morning to be with us today and for your
No worries. Thank you for having me.
We're trying into at a meeting sometime soon.
Great.
So with that, I'll just make a couple of concluding remarks, and then we'll dismiss today's program. I continue to just be enamored with this event. I think it is an incredible day, and for me, I always leave it feeling really good. It's very rewarding to see everybody here engaging with the speakers and really learning in this community that has evolved through the work of Dr. Bird starting decades ago. And so I want to thank you all for joining today in person and online. This is why the event happens. It's for you, and it's incredibly exciting to be a part of year after year. So I want to start by thanking you all for being here. I want to thank our amazing education event team, Ritu, Meredith, and Alana, without whom this would not happen. I can't tell you how many more hours they put into organizing and carrying this out than I do. And it's really only because of them that this event is such a success year after year. So wherever you are, please stand up and let's give them a round of applause. Very indebted to our speakers. Thought it was an amazing lineup of talks this year, really running the gamut of different topics, different elements of treatment and the patient experience. A special thank you to our patient story, Deb. That was truly amazing, remarkable. Thank you for sharing that. A couple administrative comments. So you have survey forms. We review these. This is actually how we generate topic items for next year or look to make tweaks to the program. So if there are things you want to learn about, Ritu and I have a dedicated meeting where we look at these, and this is how we decide what's on the agenda. So please hand those out on your way. If you can hand them back to us on your way out, that's the easiest way. But certainly reach out if there are other things that come to mind that you'd like to hear about. Also, as a plug, if you may have interest in the future as being a patient or caregiver story, actually I like the word carer that Dr. Lai-Kwon used. I thought that was nice, but I might adopt that, a patient or carer story. Please let either Ritu or myself know, either after the event today or by email. There should be a way to get in contact with us. We're always looking for people who are willing to share their stories. So, yeah, with that, I kind of dismiss today. Thank you all for being here, and I'm already looking forward to next year's event. Thank you.